Diseases Research and Treatment Association have traditionally organized the May Day event every 2 years. We are honored to be with you at the 8th May Day event in collaboration with the Mediterranean Academy of Mastology and the Faculty of Medicine of Aristotle University of Thessaloniki. This year's theme will be benign breast diseases high-risk management. The meeting will be conducted in English. We will have numerous international and Turkish speakers contributing to the discussions. Distinguished guests, welcome. Our program will continue for 2 days in 7 sessions consisting of panels, lectures, and presentations. Before we start our program, I invite you to observe a moment of silence in memory of the founder of our country, Gazi Mustafa Kemal Atatürk, and our revered masters, followed by the reading of our national anthem. Thank you. Now it's time for our university promotional film. We wish you a good viewing. Thank you so much. We would like to begin with our opening session. I would like to invite Professor Dr. Bahadır Güllüoğlu to provide information about the course introductions, objectives, and orientation.
Good morning, everyone. So this is the fresh start for the morning. We have 2 days of the course program with 7 sessions, and I would like to say welcome to all of you. And we have guests also from 8 different countries now representing their countries with the, formerly it's called MANOS-Med and MANOS-Medi, now it's called Mediterranean Association of Mastology. We have guests from Greece, from Cyprus, from Romania, from United Arab Emirates, from Malta, from Azerbaijan, if I'm not mistaken, and also from Albania. In fact, Helidon Nina, Professor Nina, cannot be with us. He will be giving a presentation about gynecomastia as a guest speaker, but he will be on video because he has an excuse and he cannot come, and he sent his excuses and apologize because of his absence as well. So today we have sessions in the morning and in the afternoon, and tomorrow we will be also continuing with the scientific sessions about benign breast conditions and also the high-risk management. And we believe that for the breast physicians, that is one of the important issues. Why? Because 80% of our patients or the women coming to our outpatient clinics are mostly benign conditions. So we're not in Turkey, for example, and I know that in many countries, and we have patients with the complaints of benign conditions, and we're dealing with them and also the high-risk conditions. So this meeting is not concentrated on cancer or DCIS or early or the late cancer. So it will be an important issue for us to give this 2 days of conferences and lectures about this, and we believe that we will be filling the gap in this area as well. So at the end of tomorrow, and also we have a young investigator session just in the morning, and that's also important for us because in order to encourage our young investigators to do and perform their scientific research and have the opportunity to give their presentations here in front of the audience. So that will be an encouragement for all of them. So we would like to have you here in this audience and to support them as well. So we will have 4 presentations from Malta, from Italy, from Turkey, and from Greece. So at the end of the second day, and when you look at the program, there's an exam. So it's always a frustration for people who are just attending this, meetings. But that exam is just a formality because this is a level 2 education, meaning that not only you're sitting here, if you would like to sit down for that exam, and if you pass it, you will have an achievement certificate. But otherwise, if you would like to just sit down and listen and do not enter that exam, you will have an attendance certificate. So at the end, please do not ask for an achievement. Why I don't have this achievement? Because if you're sitting in the exam and passing the exam, you will have the achievement certificate, which might be useful for future in any case, and will be signed by the rector of Kocaeli University and also the representative of the Thessaloniki University of School of Medicine, which these 2 universities are now making a cooperation together closely. So I would like to leave the floor to Professor Konstantinos Dinas. Kostas, can I have you here? I don't know if you would like to, I don't know how the, officially will be announcing the next speaker, but Kostas is a close friend of us from Thessaloniki, and we have a very close collaboration for the couple of years, and we have also future perspectives. No, you can come up here, please. You can come here. Welcome.
Dear friends, authorities, and most of all, dear younger colleagues, dear students, it's a very big honor for me and many of our team to be here with you. It is a big privilege because this is the start of a very deep scientific collaboration. As the key structure of the new Mediterranean Association of Mastology, in which I will have some words to you, we are on the process in establishing a master program a bilateral, bi-country master program between the University of Thessaloniki, the Aristoteles, and the University of Kocaeli regarding breast diseases. It will be an official master program accredited by the European Union, which will be endorsed and signed and accredited by both universities. It is not an easy task, it's a difficult task, but my dear friend Professor Senturk, dear Zafer, he's so kind and so willing to do this, so we are working together. It takes some time, but I believe within the end, until the end of this year, it will be ready. So next year we can take the first applications. Regarding the Mediterranean Association of Mastology, it is an organization which actually is new in the law, in the formality, but actually it's a very old one because it's the evolution of the old Manos Medi or Manos Medi, the Mediterranean Academy of Mastology. Things evolve, things change, people grow, become older, so I think also institutions have to adapt to the newest standards of education. Somebody could ask why another association, why another academic formality. The only thing actually from our point of view in which this association exists is to give the younger generation the boost they need to evolve further. There are so many associations, everybody of us has been or is or will be president of so many academic societies, national, international. It is not something which we do for ourselves. I think with the help of God we've done much more than we expected when we started studying medicine. I'm born in 67, so I'm now 58. So I think what is done is done. So the only thing which is very important for me, not only as a physician, I'm a gynecologist, but also as an academic, is to give the opportunity to the younger generation to become better than us. There is always in Greece and the European Union saying that the younger generation is not willing to work, they don't want to do anything, they are used in luxury. It's not reality. There are so many young people who want to evolve, who leave their houses, their nice way of living, and they go abroad just to further their perspectives and to become better. So actually this is the main reason why this new association was born, to give the younger ones the skills and the help they need to fly further, to fly higher, and to be much more successful than we were. It is an association in which actually all the countries which have to do with the Mediterranean are welcome. But you know, everybody in the end in this world has to do something with the Mediterranean, because water does not know any borders, and even a small river who starts maybe in Siberia or in Africa, in the end of the day, some cells from this water will come to the Mediterranean. So actually it is a society which needs to have a word, but in the end of the day it's something in which we would like to grow further and further, having as a start the Mediterranean area, in which there is a long history, a long tradition of cultural intervention, of people intervention. All the people who live in this area have much more in common than differences. So I think this is also a good start to further expand the collaboration, not only between persons, but also between countries and institutions. So I believe this afternoon we have the first official executive meeting. There has been a lot of work done before regarding to issue an establishment so that we have a signature, we have a stamp, we are a company with a real name, as all the companies have to be. and it was a big help from all the previous members who were members in the past of Manos Medi. It is a great pity that because of the now political situation, the president of the Mediterranean Association cannot be with us. Nezib Kiakan, he is a professor of surgery in Lebanon, but due to the latest circumstances, he cannot join this Congress, but I'm sure that he would like so much to be here as we all are. I represent his presence here as the secretary, and I believe that in the near future, most of you will hear a lot about this the new association. Our site is under construction at the moment. We are also producing the final steps in which we will evolve. We will talk this afternoon. And I once would like to thank Professor Senturk for his kind invitation, for this very nice idea he had, he and Professor Guloglu, to organize such a meeting about benign breast conditions or diseases, or you can call it as you like, because in the end of the day, we all would like to ask with benign cases than with malignant, although malignancy is the core aspect of our specialty. So, in the name of the Aristoteles University of Thessaloniki, the second department of obstetrics and gynecology in which I am head, I salute you, and I hope that this will be a very congress with a very big success. Thank you so much.
Thank you, Professor. I would like to invite our rector, Professor Dr. Nuh Zafer Jantürk, to give his opening speeches regarding the collaboration between Kocaeli University and Senatürk.
Distinguished colleagues, esteemed guests, dear friends, I am sorry my voice is not good, but unfortunately I will use this bad voice to address you. It is great honor and pleasure to welcome you all to the 8th May Day meeting. On behalf of Kocaeli University, I extend my sincere greetings to your valuable national and international participants who have gathered here today in the spirit of science, friendship, and collaboration. We, as breast surgeons in Turkey, started this journey at the beginning of 2005 with the foundation of Turkish Federation of Breast Societies. Kocaeli Breast Society was the 5th breast society, which is founded in 2005 and participated in the federation. And then 2010, we founded MyMed, which is a regional monthly meeting for Anatolian side of Istanbul and Kocaeli, with support of the Kocaeli Breast Society. Until today, we organize almost 100 meetings. Also, we founded Senatürk in 2011. Senatürk organized many international and national meetings and workshops for training Turkish and international surgeons. One of these meetings is the May Day. This is the 80th one of this meeting. I am very proud of these organizations, these meetings to be withheld. Scientific meetings are not merely platform for sharing knowledge. They are also bridges connecting cultures, experiences, and people. Today's gathering carries a particularly meaningful dimension because it reflects the long-standing friendship and academic cooperation between Turkey and Balkan and Aegean countries. Throughout history, the Balkans and Anatolia have shared the common traditions, cultural values, and human connections that transcend borders. In medicine, this friendship becomes even more powerful as physicians and scientists unite around the universal purpose, improving human health and quality of life. This year's focus on benign breast disease is both timely and important. Although benign breast disorders are non-malignant, they constitute one of the most common reasons for referral to breast clinics worldwide. Millions of women experience anxiety, uncertainty, and fear when confronted with breast symptoms. Therefore, our responsibility extends beyond the diagnosis and treatment. We must also provide reassurance, education, and compassionate care. The field of benign breast disease management has evolved remarkably in recent years. Advances in breast imaging, minimally invasive biopsy techniques, risk stratification, and multidisciplinary care have significantly improved diagnostic accuracy while reducing unnecessary surgical interventions. At the same time, growing awareness of the personalized medicine reminds us that every patient must be evaluated not only radiologically and pathologically, but also psychologically and socially. As breast surgeons and clinicians, we know that benign breast disease are not always simple conditions. Some lesions may mimic malignancy, while others may carry varying degrees of future cancer risk. This makes scientific dialogue and international collaboration critically important. Meetings like these allow us to exchange experiences, discuss the controversial topics, and develop common perspectives that ultimately benefit our patients. I would also like to emphasize the role of Kocaeli Üniversitesi in advancing medical science and international cooperation. Located at the heart of one of the Turkey's strongest industrial and academic regions, our university continues to expand its global vision through research, innovation, and interdisciplinary collaboration. As you have seen the film about the Kocaeli University, we have 16,000 students, including 2,000 foreign students. We have 19 faculty, 15 vocational schools, one conservatory, many research centers, technoparks, science parks. We try to make a contribution to global science. Also, we have 1,000-bed hospitals, and we are training our students for healthcare of the Turkish peoples. In healthcare science, and particularly in surgical disciplines, we strive to combine scientific excellence with human-centered care. We are proud to host distinguished scientists and clinicians from different Balkan countries, and beyond your participation, strengthens not only academic productivity, but also the bonds of regional solidarity and friendship. Science flourishes best where there is openness, mutual respect, and shared vision. In an era marked by rapid technological transformation, artificial intelligence, digital medicine, and precision health approaches are reshaping clinical practice. Yet, despite all technological progress, the essence of medicine remains unchanged. Listening to patients, understanding their concerns, and approaching them with empathy and wisdom. I sincerely hope that this meeting will inspire new collaborations, productive discussion, and lasting friendship. via this kind of meeting, I would like to tell to enlarge our network around the world from Siberia to Far East and the West with colleagues around the globe, with Turkish colleagues together. So I am very pleased to host colleagues from Balkan region, and we will make a collaboration for mastership program together in coming year. And I am very proud of it, but I am working on it. I hope so we will enlarge it to whole Europe, maybe as Kostas mentioned, to around globe. May the knowledge shared here contribute to better patient care, stronger scientific partnerships, and a brighter future for our region. I also want to announce this meeting is broadcasting via YouTube in live, so many colleagues around the globe can watch this meeting with us. Thank you for valuable participation and presentations. I wish you all a successful and inspiring meeting and well journey. I sincerely greeting all of you.
Thank you, dear Rector. I would like to invite dear speakers for first panel.
Welcome. In this session, we have a 4 speaker and 5 speech. First of all, from Medipol University, Dr. Sina Ferahman will speak about moderate risk lesions. Please.
Thank you. It's a big honor to be here. Before I starting, I would like to thank our rector, Professor Can Türk, Professor Güllüoğlu, and Professor Gençal. And I would also like to thank you, all of you. I hope we will have a productive and enjoyable 2 days course. Today, I try to talk about moderate risk lesions. Moderate risk lesions are a gray zone group. They are not clearly malignant, but they cannot be safely to ignore them. Is it a really surgical issue? I'm sorry. Now it's a little bit old school. Today, moderate risk lesions are a multidisciplinary issue. These lesions should be evaluated in 2 separated groups. One, upgrade risk factors. The other risk is long-term breast cancer risk. Upgrade means that a lesion diagnosed a benign or borderline on biopsy is found to be disease or invasive cancer after excision. For these lesions, the upgrade risk mainly driven 5 factors: atypia, radiological pathological discordance, insufficient sampling, larger lesion size, and persistent clinical or imaging suspicions. About long-term breast cancer, The key point is the lesion is pure or associated with atypia. Pure lesions usually do not create a major independent risk, and so routinely screening is often enough. In contrast, papillomas carry some increased risk, especially when they are multiple or peripheral. In the past, many of these lesions were sent directly to the surgery. Today, with better sampling and complete lesion excision removal, management has become more selective and based on radiological and pathological concordance. Vacuum-assisted biopsy has clearly changed the way. As the saying of Kocaeli, with the invention of the rifle, the old-fashioned bravery lost its meaning. So, after vacuum biopsy, our algorithm has been changed. But this is not a battle between radiology, surgery, or pathologists. One side, vacuum-assisted excision offers us a minimal invasive approach with low complication and good diagnosis. The other side, surgical excision, offers a definitely removal and greater certainty against missed malignancy. Our shared goal is very simple: to treat the patient with the lowest error and the lowest complication rate. Vacuum-assisted excision appears to be a safe approach for selected B3 lesions. But the important part of this issue is this question: which patients truly need a surgery? The first lesion is radial scar. Radial scar is one of the most deceptive B3 lesions because it's historically benign, radiologically suspicious, and clinically controversial. In simple terms, complex sclerosing lesion is larger than 1 centimeter. Radial sclerosing lesion is an umbrella term. It's included both radial scar and the complex sclerosing lesion. On mammography, especially with tomosynthesis, we usually see architectural distortion with a radiolucent center and radial specules, sometimes speculated mass. On ultrasound, it may appear as architecture distortion too, with mass, isoechoic or hypoechoic mass, and posterior acoustic shadowing. On MRI, it may appear as a speculated mass or architectural distortion too. But if there is no enhancement and the negative predictive value is very high, is nearly 99%, this creates a real diagnostic dilemma. Because of this lesion can closely mimic invasive carcinoma on imaging. For upgrade risk, the first and the most important question is atypia is present. In pure radial scar without atypia is very low, upgrade is 1 to 10%. And if you use vacuum-assisted biopsy, this risk can decrease to 1%. However, when the radial scar is associated with ADH or lobular neoplasm, the upgrade risk reaching 36%. The lesion size also matters. Larger than 2 centimeters, it carries a higher upgrade risk. And the Kaiser score is more than 7 is higher risk for upgrade risk. What is Kaiser score? Kaiser score is a clinical decision tool we use on MRI. It looks few key on MRI is like speculation, lesion margin, and edema, and a Kaiser score above 7, it's a high probability of malignancy. The Kaiser score looks complex at first because it's not a simple scoring table, but it's basically a decision tree, and we can use on MRI. I prepared 3 algorithms for each lesion. This is the radial scar algorithm. When we detect a suspicion finding, we start with a biopsy. The most important question is after biopsy is there is a atypy present or no. If atypy is present, the upgrade is clearly higher and the surgical excision is usually recommended. But there is no atypia. This is a pure radial scar and the risk is much lower. In these cases, the next question is whether sampling was educated. If the lesion was sampled only with core biopsy, this may not be enough sometimes. So vacuum-assisted excision or larger volume sampling is preferred. But if the lesion was well sampled, completely removed, and the radiological pathological are concordant, the imaging follow-up enough for us. Okay, what should be the management if the radial scar with atypia has been completely removed by vacuum-assisted biopsy and no residual lesion? What will we do? This is a hard question. This is a gray zone group. We discuss the case in a multidisciplinary team. But surgical excision is generally recommended in most cases. The main reason is to rule out an associated focus on DCIS or invasive carcinoma. Okay, this is the second lesion. Papillary lesion is one of the most common one, and most of them are benign and intraductal papillomas. They have a fibrovascular core covered by two epithelial layers. This is not a one lesion, this is a spectrum. In the beginning, this is a benign, a pure papilloma, and at the end of the spectrum, you see the papillary DCIS. So the key message is very simple. Not all papillomas are the same, and management must depend on where the lesion lies on this spectrum. An important pathological point is that size threshold is different inside a papilloma. While the usual cutoff between ADH and DCIS is 2 millimeters. But within a papilloma, the threshold is 3 millimeters. And this becomes a key diagnostic distinction for the pathology. On ultrasound, well-defined nodule, vascular stalk or small mass within dilated duct. On mammography, retroalar mass or polymorphic clustered calcification. And on MRI, papilloma often appear a well-defined enhancing mass. The upgrade risk is not the same for every papilloma. Atypia is the strongest warning sign. Bloody discharge, a palpable mass, larger lesion size, multiplicity, peripheral location, and a high Kaiser score all push us towards a more careful approach. Atypia is the key point. A pure papilloma has low risk, but when atypia, especially ADH, is present, the risk increasingly clearly much more higher. The multiple peripheral papillomas are more likely associated with ADH or DCIS compared to solitary central intraductal papillomas. Papilloma risk is mainly driven by atypia. Poor lesion can carry about a twofold risk, multiple papillomas about threefold. But atypical atypia and multiple papillomas may increase seven-fold future cancer risk. This is algorithm for papilloma. The algorithm shows a practical way to manage intraductal papillomas. We start with a biopsy too. We start with a biopsy, either core needle biopsy or vacuum-assisted biopsy, depending on the lesion. If the patient has bloody nipple...
Dr. Ferahman, time is...
I have 15 minutes. Okay. After biopsy, the key question is whether atypia is present or not. The papilloma contains atypia, the upgrade risk high. If it is pure without atypia, it's much lower and If it's completely removed by vacuum biopsy, it can be followed by imaging. This is the last one. Flat epithelial atopy is a part of the columnar cell lesion spectrum. It's usually detected on mammography as grouped amorphous calcification. Ultrasound is less helpful, but MRI, flat epithelial atopy lesion, the literature is becoming more clearly. A negative contrast enhanced MRI is also very helpful and very high negativity predictive value for excluding invasive cancer is up to 98%. The sizes matter. It's larger than 2 centimeters. The risks up to 20%, and surgical excision is more appreciated. The flat epithelial atopy usually has a low grade if it is pure, and after vacuum biopsy, risk drop to 0 if 90% of the suspicious microcalcification are removed. The main risk factors are the concomitant ADH, large lesion size, poor sampling, residual imaging finding, and the older age. This is the summary of the all flat lesion, but if there is associated with ADH or another higher risk lesion, the approach is clearly high and vacuum-assisted excision is usually required. Okay, in B3 lesion, the key issue is not only immediate risk upgrade, but also the patients must know long-term risk of developing breast cancer. Endocrine risk reduction is not indicated for every B3 lesion, but in selected high-risk women, it can reduce the future risk of ER-positive breast cancer by nearly 50%. But the real challenge is not the lack of evidence. The gap between evidence and the practice, mainly driven by side effect, communication problem, and the absence of a clear prevention pathway after B3 lesions. Chemoprevention is not a single drug concept. The choice depends mainly on menopausal status. Tamoxifen has the strongest classical evidence, but raloxifene and aromatase inhibitors are important alternatives for post-menopausal women. Lifestyle counseling is not substitute for proper risk assessment, but every patient with B3 lesion must be taught smoking cessation, weight control, regular physical activity, and reducing alcohol intake should be part of the prevention strategies. Shared decision making is essential. This is the last slide. Patients should understand both the short-term upgrade risk and the long-term breast cancer risk, but also the possible harms of the over-treatment, anxiety, and treatment-related side effects. It is necessary to remain under close clinical and radiological monitor. Therefore, the final decision should combine evidence, individual risk profile, and the patient's values and preferences. Thank you very much.
Thank you very much. The management of this kind of lesions is really important. We decided to take questions and comments at the end of the session, if any. The next speaker is Dr. Ahmet Erkek, is going to talk about pseudoangiomatous stromal hyperplasia. Dr. Erkek.
Thank you very much. It was a great honor to be here. First of all, today we are going to speak about the pseudoangiomatous stromal hyperplasia. It was a rare lesion in the breast, but the treatment and the other way is so important of all of us. And we start with this one. PASH is an overgrowth of myofibroblastic cells in the breast. It has an appearance similar to fibroadenopathy changes. Pseudoangiomatous hyperplasia, we first of all that was the benign lesion. And some of the cases have breast cancer also because of the pseudoangiomatous hyperplasia, but lots of them have a uncertain currently significance and they are benign. Other cases have made screening for breast cancer difficult and in some cases impossible due to the number and density of the existing PESH tumors. Here, the etiologic driver, we altogether see the mean age nearly 37 to 40, primarily premenopausal women, and in the hormonal axis, driven by an X-rated stromal myofibroblast response to hormones. Exogenous triggers strongly associated with iatrogenic hormonal augmentation. The clinical spectrum, we first of all, the most common one, focal and incidental one, in the microscopic discovered incidentally in biopsies performed for independent indications. The second one, nodular or tumoral lesions, the patient or the doctor will have. And the common clinical presentation is this one, palpable, painless tumors. This was a painless, it's important I think for you, mobile and firm masses. The diffuse one is very, very rare, but rapid extreme breast enlargement resulting in the gigantomastia. The pseudoangiomatous hyperplasia, the diagnosis is the biopsy. The important differential diagnosis is angiosarcoma, from which it was first differentiated in 1986. First of all, let's look at the differences between them. The PESH and low-grade angiosarcoma, first of all, the differences is the origin. The origin in the PESH is myofibroblastic cells, but the low-grade angiosarcoma comes from the vascular area. The intraluminal erythrocytes, in the PESH, we see no erythrocyte, but in low-grade angiosarcoma, erythrocytes are present. CD31 is so important. In PESH, it's negative, but in low-grade angiosarcoma, we see CD31 positive. In the future, we will see in PESH, the CD42, the stromal cell marker is positive also. And the last difference between them is the atypia and mitosis. In PESH, no atypia and no mitosis, but in low-grade angiosarcoma, we see prominent mitosis. In the microscope, it's much more than 10, maybe. The differential diagnosis, low-grade angiosarcoma, we see it's the CD31 positive, and factor VIII will be there because of it's coming from the vessel. And myofibroblastoma, you see, it has the gene, retinoblastoma, 13q14, it's come from there. And the other spindle cell tumors are rare, and they are coming from the fibromatosis. And the radiologic evaluation of this one is the ultrasonography and mammography. And as the patient's age is smaller than 40, we always use the ultrasonography. But if it's higher than the 40, we use always the mammography. There are key differentiation in here. Typical lacks of calcifications will be seen in mammography. They may contain internal cystic spaces. It will be seen in the ultrasonography. And that was a picture about the PESH, pseudoangiomatous stromal hyperplasia. You see the picture. It's the mammography picture. It was a benign lesion. It's seen a benign lesion. And the ultrasound, like a cyst, like a solid tumor in mammography, have a little spaces like the cyst. And the pathology is so important. In MRI, it has a benign kinetic profile, and it's the MRI picture. Sometimes, but rare, it will be a much more big tumor, and you are going to make the surgery maybe. And we talk about the CD31, CD34, and the other ones. It was found in 1995, you see, the ER positive, the PR, the progesterone receptor, estrogen receptors are positive, and vimentin also positive from the structural area, and CD34 is so important for this tumor. It is also positive in the bone marrow cells, in the stem cells. And because of this one, they thought that it's coming from the stem cells. The tumor is coming from the stem cells. And the CD31, we talked about this one. They are positive in the angiosarcomas and the other ones. I think this picture is so important for you because of the pseudo. What does pseudo mean in pseudoangiomatosis stromal hyperplasia? You see, we called it about pseudo because there is no erythrocyte in the vessels. Because of that, they are calling the tumor pseudo. Is so important, this one. In the lining spindle cells, we see the spindle cells here. In the network slide-like anastomotic spaces and the matrix dense collagenous stroma. I think the most important for this lesion is in the pathology, CD34 is positive for this tumor, and CD31 is negative. And factor VIII also negative because it's not coming from the vessel. And this is the pathologic view. Last two slides, we talked about the spindle cells. In this pathology, we see the spindle cells outside the tumor. And pseudoangiomatous hyperplasia have cystic areas, but no vessels is so important in the pathology. The management of PASH is controversial. Excision may be indicated in enlarging masses or lesions with atypic features. We always don't make any surgery if the tumor is not so much big and the other excisions criteria. Here, I think 2025, the American Society of Breast Surgeons, they talk about the indications of PASH. And the PASH is characterized by myofibroblast proliferation mimicking a vascular lesion. It can be found incidentally on biopsy or may present as a mass or enlargement of the breast. When PASH is identified on biopsy, the pathology considered concordant with imaging, surgical excision is not necessary. I think this is so important. Surgical excision is not necessary for this tumor. But if the tumor goes on, the tumor are bigger, or it has enlargement and any other problems about the tumor, for example, bleeding, for example, necrosis and the other ones, you should have to make the surgery. And biopsy-proven PASH, after this one, observation and surgical excision, we have two-way. The criteria, small asymptomatic incidental findings confirmed by core needle biopsy, action, routine, clinical, and radiologic follow-up. We always follow up these lesions, but if they are large, if rapidly growing, or clinically symptomatic masses, for example, painless or the other one, we are going to make surgical removal with clear margins. And after the surgery, the prognosis and recurrence, my last slide, use the 100 in 100% is benign, but if it carries a little bit surgical weight, if you couldn't take the tumor outside, 15 or 20%, it will make another tumor, it will come, they will come again, and you're going to make any other big incision for this one. But all of the tumors are benign. We are not going to afraid because of these tumors. Thank you very much.
Thank you. Now, the third speaker is from Azerbaijan Medical University, Dr. Kocaeli Aliyeva, and she will speak about hamartomas.
Good morning, everyone. First of all, I would like to thank all of organized course and especially Professor Dr. Zakar Hoca and my mentor Bahadur Hoca for this opportunity to be here. Today I will talk about breast hamartomas, their clinical features and imaging findings, when and how we should treat them surgically. Breast hamartomas are rare benign tumors composed of disorganized native breast tissues such as ducts, lobules, and stroma. Commonly affect on middle-aged women on their 40 or 45 age, composed of normal breast tissues arranged in a disorganized manner. Increasing number of report cases in recent years, probably better imaging techniques. Diagnosis requires correlation of clinical, radiological, and histological findings. Important to consider the differential diagnosis of other breast lumps. Hamartomas historically first described by Prine, then previously reported under various names, lipofibroadenoma, fibroadenolipoma, and others. Then term mammary hamartoma introduced by Arikin and included in World Health Organization tumor classification. What is a breast hamartoma? Breast hamartomas is benign tumor-like lesions. They composed of mixture major adipose tissue, fibrous stroma, normal glandular breast elements, represented disorganized overgrowth of native breast components, typically surrounded by a thin pseudocapsules. Due to mixed breast elements, soft tissue and glandular and fat tissues, typically breast within a breast sign is common radiologic hallmark. According several cases and the last literature reviews, the incidence being among benign tumors range approximately from 0.7 up to 4 and 8%. Most commonly affects women in their 40s age. Rare case reports have been documented on male, also children. Frequently underdiagnosed due to low awareness, core needle biopsy, ultrasound, mammogram, sometimes MRI, and biopsy for confirmation have been provided. Exact pathology remains still unclear. Considered as a result of development disease, not a true neoplasm. Possible role of hormonal influence given peak incidence in premenopausal women. Rare association with stone hamartomas tumor syndrome in Croden syndrome. Histopathological features, macroscopically, the key features, their hamartomas are well circumscribed, soft form, smooth nodular mass, surrounded by a false pseudocapsula. Microscopical features, disorganized mixture of fibrotic stroma, normal breast lobes and ducts, sometimes small muscles and cartilage can be. Most commonly painless breast lump. Patients present most commonly painless lump, so chronic mass, soft and mobile on palpation, usually no skin chair, but when the lesion becomes larger and on giant hamartomas, we can see breast asymmetry and cosmetic deformity. This is, for example, a 36 years woman with giant hamartoma, and she had previously contralateral breast cancer. She treated by breast conserving surgeries and endocrine therapy and radiotherapy. On ultrasound, we have some characteristic features. First of them, the fibroadenomas, well circumscribed oval mass, parallel orientation relative to the skin, and their key features, heterogeneous ecostructure due to mixed fat and fibroglandular components, thin echogenic capsule surrounded by lesions, smooth, well-defined margins, no posterior acoustic shadowing, minimal or no internal vascularity on Doppler. We can see on imaging, ultrasound imaging, well-defined and clear margins and pseudocapsules here. Mammogram also has some character sign. The case of features, mammogram features, is breast of breast sign due to mixed tissues and smooth node without speculation. This is also mammogram views. MRI can be provided if mammogram and ultrasound not typically shows hamartoma signs. This is And differential diagnosis of breast hamartomas is very important. We can see differential summary in this table. Hamartoma can be differentiated from other breast lesions by their presence of mixed adipose and fibroglandular tissue and the characteristic breast within a breast appearance. Fibroadenoma sometimes can mimic hamartoma, but hamartomas inside a lesion, we can see usually, especially on ultrasound, we can see mixed stromas and fat tissues. Fat necrosis also can mimic hamartomas on ultrasound and on mammogram views, but always has history, trauma, or surgery. We can see this image fibroadenoma, hamartoma, and lipoma, and also we can see breast within breast signs on mammogram views. Also sometimes phylloid fibroadenomas can coexist with hamartomas, but also phylloid fibroadenomas have a hypoiconic solid lesion, but not hamartomas. Breast hamartomas in male are extremely rare. Only a small case have been reported. And clinic features, imaging findings same as what we can see in female. Also we can see male breast hamartomas image. Also in children is extremely rare. Only 7 cases have been reported. One of them, 13 years boy, he has giant hamartoma, approximately 10 and 10 centimeter, and here we can see scan areas. Malignancy risk very low, overlook breast hamartomas and has a low risk of malignancy. Rare case of carcinoma report within hamartoma, invasive ductal carcinoma, DCIS, but reported in the incidence of carcinoma within hamartoma is extremely low, less than 1%. Surgical excision is simple as other breast lesions. Surgical excision is recommended, but not every case requires surgical, immediately surgery. Surgical excision is recommended in the presence of progressive increase in size, symptomatic pains of discomfort, and in giant hamartomas and large hamartomas when they present asymmetry and apoptosis. Breast hamartomas, according to the management, we can say breast hamartomas seen of median age 13 years, premenopausal women, most commonly paleness and mobile palpable mass, but only 21% detected during follow-up. Imaging combination with ultrasound, mammogram, and MRI, and biopsy can be performed. Preparative assessment before surgery. Clinical examination is very important. Lesion size, mobility, breast contours, ultrasound first line, mammograph and MRI, as I mentioned before, and core needle biopsy can performed if diagnosis is uncertain. Primary surgical objective, complete excision of lesion, preservation of surrounding of normal parenchyma, optimization of cosmetic outcome. Surgical management should be based on lesion size and breast tumors. Excisional lumpectomy is standard surgical techniques. Also, incision depends on localization and size of size of hamartoma, and we can prefer periareolar and inframammar fold incision. Reduction mammoplasty techniques also can be provided if large and giant hamartomas, and giant hamartoma, as I mentioned before, is means of distortion of breast contour ptosis. That's why contralateral breast asymmetry also can be provided. Postoperative pathologic evaluation. Pathologic assessment should confirm complete excision of the lesion, typical hamartomas architecture, absence of epithelial atypia, exclusion of in situ or invasive carcinoma. Margin status is generally not critical, but should documented if malignancy is detected. Overall prognosis is excellent. Recurrence is extremely rare. Complete surgical excision is curative in the most majority of cases. No evidence of aggressive biologic behavior. Breast hamartomas not considered as pre-malignant transformation, but transformation is possible due to the presence of minimal glandular breast tissue. Follow-up also straightforward after complete excision. Recommended approach routine breast surveillance according to standard screening guidelines. No additional oncologic follow-up required on purely benign hamartomas. Enhanced follow-up incidence only if pathology reveals epithelial atypia, in situ carcinoma, invasive malignancy. In my practice, I usually not operate all hamartomas. If clinical findings are clear, and if I prefer to do biopsy, if biopsy also confirm hamartoma, I prefer follow-up and clinical and radiological follow-up. Thank you for attention.
Okay, now we'll introduce the last speaker, Professor Dinas from University of Thessaloniki, for a very frequent condition, fibroadenoma and philotumor.
Respected Chair, dear friends, it will be one presentation actually. There are two, I was allocated to two, which is the fibroadenoma and phyllodes tumor. But in the end, you will see that there's something much more in common than we actually think they had. So I think it will be one presentation in two parts. So it goes like this. Yes, I have no conflict of interest. I'm just a gynecologist, nothing more. Not a very successful one, but I try to do my best. So now we'll talk about, first of all, to fibroadenoma. Fibroadenoma is a very, very usual finding, especially in young women. We find it very often. It is benign, and usually it does not pose any problems. Usually there's much more a hype concerning the fibroadenoma that it is worth. But there is always a problem about communication between doctors and patients. It's not usually what something is, it's something what should or something what could. So if you are discussing with the buyers if something should or if something could, you may operate everybody you see in life, because everything in life should or everything in life could in the end of the day. But the fibroadenoma is actually a very benign situation. It goes like this. Is it going forward with this? No? Super. So there are some special subtypes of fibroadenoma. Usually we do not care what subtypes they are. They are because you can see it in books, you can see it in papers. It is a juvenile. Yes, we can see it in young patients, we can see it in young girls. Usually they come like this. They hide it from the mothers. They come, the mothers comes usually, oh, what is this in my child? Usually it's nothing, it's just a big fibroadenoma in the adolescents. You have giant, you have big fibroadenomas, but usually something which is very big, usually it is not malignant and it's not that many, not so much important. Here is the problem, sometimes you have complex fibroadenomas. A complex fibroadenoma may pose some risk for breast cancer, so you have to be very carefully regarding the management of this. If it is a complex fibroadenoma, it's the only time I encourage to remove it regardless of size, because there are some papers. One, Stefanos, my friend, told me about it. In Israel, it was published, they had a large series, and we usually remove it if it's like this. Cellular, it is much more cellular, but it is not a phyllodes tumor, so we actually do not care about this. And if it's a mixed, it's just a degeneration of a fibroadenoma, which is not a problem. So usually the symptoms, you are all familiar of it, because usually all of you had one or more, or usually many cases with fibroadenomas in the past. Usually you have a lump. Usually the girl comes of her own, the young woman. She feels it. Sometimes it's tender when it has to do with PMT or in the end of the cycle, and it resolves spontaneously with the beginning of the cycle. And usually it is palpable when it is superficial. If it is deep or if you have a big breast, you are not able to palpate it if it is less than 2 or 3 centimeters. So the clinical examination always helps, as helps the history. Usually we have the 3 tools in which we have to evaluate all breast lesions, regardless if it is a hamartoma, which we discussed previously, if it is a pus or whatever it is, you do mammography, you do ultrasound, and if you don't find a conclusion, you do an MRI. For fibroadenoma, usually, because it's also in younger women, less than 30 or less than 40, where the mammography doesn't have any proper sensitivity, it is useless. If you have a dense breast, you do an ultrasound. And usually in ultrasound, you find a conclusion, and usually you are absolutely sure that it's a fibroadenoma in 8 or 9 out of 10 cases. You can do a mammography. Usually you don't need it. If the woman is more than 40, you should do it because it's a legal requirement, at least in Greece or in other countries I know of. I don't know how things are in your country, but we do it if the woman is more than 40. And if you cannot have any conclusion, then you do an MRI. So if you have all these pictures, you know that it's a fibroadenoma, and in most of the cases, you don't need to do a biopsy. If you see the first time, it's a lesion, a BIRAT 3 lesion. BIRAT 3 lesion means that it's a lesion which cannot be forever a BIRAT 3, as usually the case is in Greece. A BIRAT 3 lesion is a preliminary result, which means that you have to follow this woman up every 6 months for 2 years. After 2 years, this lesion has to become a 2, or if you have a problem, you do it a 4A and you do a biopsy. You cannot have a lesion which is a BIRAT 3 for 3, 4, 5 years or for a lifetime, as we see it in real life. So if you do this, and if you know that it's a fibroadenoma, you evaluate it with these 3 modalities, with this ultrasound, mammography, and MRI if needed, and you come to a conclusion. If you have a real problem or you are not sure about it, do a biopsy. Do more a biopsy, do one biopsy more than one biopsy less. You can do an FNA for a benign lesion. It is a very, very good result. If you have a BIRAT 3 lesion, you think you have a fibroadenoma, the woman is not pregnant, you can do an FNA, fine needle aspiration. It has an excellent prognostic value, and also if you have cancer. But if you have a BIRAT 4A or B, we never do an FNA. But here you can do one, but of course the gold standard is also the core needle biopsy, in which you get results, and if it is something worse than this, you can have also subtypes, receptors, etc. So now you know you have a fibroadenoma. What you have to do? You don't have to do anything. You never ever have to remove a fibroadenoma, except it is a complex one. When do you remove it? You remove it when it is increasing in size. Which size? Actually, nobody knows. There are people who talk 2 centimeters. I think it's nonsense. 3 centimeters starts to make sense. 4 centimeters in superficial ones, and in young ladies, which you see the deformity just, visually, I think it is a must. But I think you have to think about 3 centimeters and above, and if it is increasing in size. If it is increasing in size and quickly, then you have to think about a filler 2 more, which we'll talk in the end. But usually you don't have to do anything. If you have to remove it, of course you can do it with open surgery. If it is proven with biopsy, you can do it with cryoablation. It's an emerging technique. You can do it with radiofrequency, which we start doing in my department now. You can do HIFU. HIFU is very expensive, needs theater, needs a lot of money and infrastructure. We will never adopt it because it is only there where, let's say, excellence in academic is driven by industry, and we don't have an established industry in this. And of course, there have been some methods trying to solve it by medical treatment. So, surveillance, the most important of all, you just watch it and you don't do anything. Just have it in mind for 2 years to observe it, and then according to the age of the woman, her preference and the guidelines, you do what you have to do. Here it is, should, could, and all of this. Usually, as we talked, you don't have to do anything, especially if you have a core needle biopsy with which you are absolutely sure that this is a benign lesion. It is not like a papillary lesion. So it's like a papilloma, in which papilloma, the role of the core needle biopsy is quite gray, because you may miss the places, because You know, it's like a grape. It is like a grape. It's the papilloma. There may be an area where you have malignant transformation. The rest is fine. But fibroadenoma, it's always the same. Wherever you put the needle, it is the same. So you have the result, so you can be absolutely sure. And of course, there are some cosmetic issues you always have to remember. What do? You do oral lumpectomy if you are absolutely sure of. Sometimes, if you're not sure, you may take some bigger margins. This is a surgery Georgia made here. She's sitting there next to me. Is it working, Georgia? You told me how to do it. I don't know how to do it. There has to be here something you told me. Oh, yes, you see? So this is Georgia operating. Yes, I'm drinking coffee as always. This is very good in life. When you become older, you can drink coffee so the younger staff can operate and you can watch, you know, do academic work, which means look what's new in the internet, you know, or this. So it is going forward. How can we do it going forward? There has to be, no, this is not a touch screen. Is it going like this? No. Okay. We are going back. No? Okay. She did it fine. The cosmetic result was excellent, as she always is. So she's much better than me. So you can be absolutely that in the after one, you could not even see the scar. Vacuum-assisted biopsy, something we do it, the radiologists do it. It is fine. It is safe. You don't have any problem. Sometimes you may have a recurrence because there is still a place, something you live inside and it grows, but this is also not a problem. You can do it again. And cryoablation. Cryoablation is an emerging technique. It helps. It is good. It has very good results in benign lesions. You don't have any problem. You have to assess the patient, and it helps. It is something in which we will hear more and more in the future, because we as surgeons, we do not have to do much with industry, but here it is industry, and the industry is not finding the one who are giving the medication, they're finding us, so they will contact you more and more by the time, so this will become much more, frequent in the future. And radiofrequency ablation, this is another technique. I think this works better, and we know that it works better from the preliminary results we have from the cancer patients. We know that from cancer patients, the one who had cryoablation and the one who had radiofrequency, the one who had radiofrequency has a much lower recurrence rate. It's 0.6 compared to 4.5%. So if it works better in cancer, it certainly works better in non-cancer. So this is what we adopted in our clinic, and we start to work with it for the last months. It makes sense. It is not that expensive. And it is good value because not many young girls want to have operations. And HIFU is also a technique. I do not have any experience with this. It is very expensive. Only the machine costs about 800,000 euros. We do not have the money to invest in, so we will not use it. But in centers who have it, why not? There has been some thoughts about pharmacological treatment. They thought about if you minimize the estrogen with giving anti-estrogen medication like aromatase inhibitors or tamoxifen or you know, all the rest, or even GnRH analogs, you may help. There was help. The help was temporary, and there were a lot of side effects. So they abandoned it because you cannot give tamoxifen to minimize fibroadenoma. It is really difficult. My friend Sadaf Alipur in Tehran, she tried and she had very good results with metformin. It is a good work. It didn't proceed. After her, nobody else worked on it, but probably in the future, maybe Stefan always has ideas like this to give strange medication to strange situations. I always say no because I don't have time, but he always thinks about new things, and some of them we adopt, maybe adopt this also. So we continue. So this was the first half. I hope I was in time. We go now to the second half, which you will see in the end. It's more related than we thought in the past. Because in the past, we believe that these two are two total different entities. Fibroadenoma is something which is totally benign, but a phyllodes tumor could be benign, could be transformed from benign into malignant, and we know this because we know how they evolve if they have a recurrence, and there is, of course, the malignant phyllodes tumor. This is another entity which has stromal and epithelial elements, And we know that we have a hypercellularity in the stroma, and this leaf like the onion, so it's like leaf. So actually the tumor, it's like an onion. You take the leaves, and in the end, you have the core of it. It is a wide spectrum of atypia. Sometimes could also not be present. So you have all these three categorizations of this. And you see here the three subtypes. It's all these three characteristics they have. And according to them, which is the tumor border, the cellularity, the atypia, the mitotic activity they have, the overgrowth, heterologous elements, and for some people, not for all, also the fact if there is a necrosis, you can categorize them if it is a benign, a borderline, and a malignant one. So these are the usual cases. Almost 3/4, 75% are benign, and the rest is borderline or malignant. And this is also the rate of recurrences regarding the post-operative period. Usually the woman comes, it is a young woman, little bit older than the one with fibroadenoma. She comes with a mass, you examine her, you see the results, you do the biopsy as we did before. Always regarding a breast lesion or a finding you have. You always have to use these three modalities. In younger women, first the ultrasound, then mammography. In older women, first mammography, then ultrasound, and MRI when it is indicated, or when the radiologist, which is the first who usually sees them, cannot use a conclusion. In Greece, we have a very big problem because ultrasound and mammography are not paid well by the state system of reimbursement. Radiologists ask most of the time also for an MRI because an MRI is quite expensive, so they get a lot of money. So we have a total overuse of MRI of the breast. But this is the system how it works. Usually we as clinicians, when they come first to us and they don't find it on screening or they don't go to have a mammography or an ultrasound first, we usually do not need an MRI for this patient. We see it, we do the biopsy, so we are done. So this is the usual picture of a phylloid. It doesn't have that big differences. The books say about fibroadenoma. Yes, it may have, but it is so easy to take a fibroadenoma as a phylloides or a phylloides as a fibroadenoma. Usually, as when you see giant fibroadenoma or the fibroadenoma which is evolving very quick, you can never ever find the difference. So the difference is found only by the pathologist on the histological specimen you take by the core biopsy. So you see real pictures for patients we have in our clinic where you have mammography, ultrasound, and the MRI. So you do the biopsy. In this case, core needle biopsy is superior than FNA. When we have a suspicion of phylloides, we do not do an FNA. We do an FNA only for patient anxiety in girls, which we are almost absolutely sure that it's a fibroadenoma. So you just do it, not even local we use for FNA, nothing. You do it in the outpatient, she goes, and in 2 days we have the result that there are benign cells in there, so there is no problem. But if you have the smallest suspicion of a phylloides tumor, you always do a core needle biopsy. So when you have the result, is what you do then. Of course, the first of all in phylloides tumor is surgical excision, and then there are the other treatments you may do or not. So surgical is the one, the gold standard you have to do. What do you have to do? Of course, you have to excise it. There was a lot of discussion in the past about your margins, and we always knew that we have to have at least 1 centimeter margins from all the aspects of the ball of the tumor, which is quite a lot, because if you think that this is a big tumor, usually more than 4 or 5 centimeters, and you take also 1 centimeter and you put this into the space, not in 2 dimensions, in 3 dimensions, it is a lot of tissue you actually sacrifice just to remove a tumor like this. So there has to be a lot of discussion what to do, and a lot of discussion because then you do a remodeling, and maybe sometimes you have to reallocate breast tissue. If you have to put clips in the edges or not, it is a good practice. Usually we do not practice it in our department. Of course, we know that even if it is a malignant tumor, it doesn't spread through the lymphatic system. It gives hematologic, it gives from the arteries, from the bloodstream metastasis to the liver or the brain, so you don't need to evaluate, and it never ever actually gives metastasis to the axilla, so you don't have to do any axillary evaluation. There are many recommendations about this, but now we know, I don't want you to read all this. There's no question also about this for the exams. The question I gave, they are very easy, so sit the exams, you will, without questions, you'll pass. They are very easy. So you just do the examination. Because you do not know how the breast comes in the end of the day, you always have to think that you need to remove more than you initially thought. So you have to discuss with the woman that first you need to remove more, and maybe then you have to make a symmetrization of the other breast. So you have to be prepared before. So actually, as you all know, most of your breast surgeons, the operation is done many hours or days before you do it, because when you know what you have to do and you have drawn your lines, you know what you do, then the other one is just, the part you don't want to do. So there are other people who do it better than us. So you do this, you have the result, and when the result is fine, then you know that you don't have to do anything, and this was the result. Afterwards, it is the same one as previously, so the result is good, and then you just wait the news from your pathologist. So this is actually the algorithm. You have benign, borderline, and malignant. If you have involved margins, so there is what we say, on ink you have a problem, you have to re-excise. If not, you are finished. If it is borderline and you have involved margins, you have to re-excise. And if it is clear, you have to discuss in the multidisciplinary team if you offer radiotherapy, usually maybe radiotherapy, or something more. But if it is malignant, there it is where you actually, it's good to have good clear margins for at least 3 millimeters, which is actually what we use in our institutions. If it is more than 3, it is okay, but if it is less than 3, then you have to reoperate. Regarding radiotherapy, it may help, it may not. It is usually the concept of the stromal sarcomas of other tumors. It does not go 100%, it's not parallel malignant phylloides tumor with a stromal sarcoma, but you can use this concept in this treatment, so it's actually what the radiotherapist would like to ask and how he sees this patient, so we discuss and take the decision accordingly. Chemotherapy, there is actually no recommendation, except if you have other problems, like you have distance metastasis, in which case actually there is actually no need to operate because you cannot cure this poor woman anyway. About adjuvant hormonal therapy or anti-hormonal therapy, there is also no need for this. And you see metastatic disease. Sometimes you see metastatic disease there where you do not expect to have it, but it can occur. There are also people who are born with less luck than some others, and this woman belonged this. It is usually brain or lung, and in this case the story changes a lot, and it is a not curable disease. So this is actually the follow-up. If it is benign, actually there is no special follow-up. You see her, you do an ultrasound every now and then, let's say between 6 months and 1 year, and after 2 to 3 years you are fine. If it is borderline, if your margins are involved, you have to be more careful. You have to see the woman every 6 months. If it is a borderline, she needs a more tight, a more close, a more good follow-up. You have to see with annual mammogram and every 6 months an ultrasound to see. An MRI you don't need to do, because in the end of the day, you will have sooner or later the outcome in the ultrasound or in the mammogram. And here it is, when you have a recurrence, usually, but not always, phylloides tumor recurs as it was previously. Usually, most of 50 to 60% like this, but there are cases, of course, if it is malignant, you cannot have a recurrence as a borderline or a benign. There is no deal about it. But if it's a benign or border, even a benign can recur as a malignant. Not very, very often, but it can. So you have to be absolutely sure about the margins that you have removed it. We are usually we sleep better if we have clear margins all the time. For local recurrence, we don't need to do anything big. You just have to reoperate, especially if it is a borderline or if it is a benign. You just save the area, you take it out, and you are finished, and there is no special treatment after that. All these guidelines, you know them, you can take them for free from NCCN, and here is where the story changes, because medical oncologists, because they have to do a lot of the genetics, they try to find why some, or if they're all good, well-operated ladies, why some of them recur and some of not, if it doesn't have to do with a surgical skill, and if it doesn't have to do with metastasis in the other part of the body. So they went into the genetics, so they find some mutations which are in these women, which are responsible for the recurrence. So they find some genes, and one of the most important genes, the MED12, a transcription regulator, and then they find some other genes. And when they find some genes, and they make some conclusion why some of the operated recur and some of not, then they found that this role of genetics does not only apply to phyllodystomy, but also to fibroadenoma, because a big majority of women, as you see, the MED12 is found in the most of the women with fibroadenoma, and a lot of with phyllodystomy. So actually, in the last years, the thinking went down from surgery or from imaging, but it went to genetics, to find which are these players which have a problem in the future. They are working on it, and we know, because this is this difficulty, we have sometimes diagnostic difficulty, we do not know what it is. We cannot stratify the woman, find the patients according to the risk, and we need to know the biology for the recurrence. So we know now that there are these key players, these genes, which could produce a problem, and it's not that we know why you have a problem. It is very important that because of this, you may be able in the future to find some therapies according to the type of gene mutation you have. So actually, this is the new thinking, that you have the normal stroma. For some reasons, it's MED12, it becomes a fibroadenoma. Usually it sleeps, but some of them, for some other epigenetic reasons and some other mutations, become phyllodes tumor, a benign one, a borderline, a malignant, and in the end of the day, if you are unlucky one, as we said, then you have a metastatic disease. So now, as we saw some previous presentations, AI is helping a lot. We have in our department an AI expert. He's a professor of informatics, so he helps us a lot. I don't understand exactly what he is doing. He always wants picture and histology results for us. This is the only thing I gave him, and he makes big proposals and big projects with the European Union and Commission, and it seems to be working fine. So I think AI is helping a lot of us. I am in a generation in which I will not see that big evolution, but the younger ones of you surely will see it in the future. And this, because this also is not yet implemented in the practice, we usually start to thinking still in fibroadenoma and in phyllodes tumor according to imaging and according to surgery and pathology. There are some minor differences between the scientific academy and committees regarding how to stage, how to follow up this patient. Usually there are no big difference. So the national guidelines, what we do in Greece, because we are a very small country, we are half than Istanbul, so we usually take the guidelines from other countries and try to adopt it to the Greek reality. But the guidelines are guidelines, and medicine is unique wherever you are. So actually, for the end of the day, the two last slides is the differences which we saw between fibroadenoma and phyllodes tumor. Fibroadenoma is in younger women. It grows slow. It's small in size. Usually it's mobile and smooth and not that firm. Homogeneous. You do a biopsy, you have a histology, and the treatment, it could be in fibroadenoma, but it has to be if it is a phyllodes tumors. So usually for fibroadenoma, it's very good just to have a surveillance and only to intervene if there is something in which causes concern. But for phyllodes tumor, you have to be very careful. It's good to have a good margin, and if you don't have the margins you would like to have, you have to have negative margins. You have to observe closely, and if it is something which is malignant, then the MDT plays a very big role. And I think I'm done with this. Thank you so much.
Yeah. Okay. Now it's time for question and answers from the floor.
Tamer. It's only, first of all, you don't see the homogeneous appearance usually in ultrasound. It doesn't have feature of degeneration, but it is not the real potato you see. You know, it is, even if you have a fibroadenoma or you have a fibroid, because we are gynecologists, it has the potato appearance. It is everywhere the same. It doesn't have degeneration. It doesn't have calcification, especially if you see it. If you have a fibroadenoma, which you have carried for 20 or 30 years, you may have calcification, but not in a young patient. He will put it 4A. Yes, or 4B, I know this. But the radiologists always want to have peace in mind, and he always put it one step more, and then write clinical reevaluation. So we know this, yes. But with a complex, it is a 4A complex, because it doesn't have the appearances of you know, the real potato appearance. Yes.
Okay. I have one remark for Kostas. Thank you very much. In my opinion, I think that I agree with you regarding young patients that you could perform FNA, but in general for older women and for a tumor bigger than 2-3 centimeters, I recommend core biopsy. And we had 2 cases with FNA negative, and these continue to grow. And after the core biopsy, it was actually a DCIS. And we should not forget that about 2%, and in some series a little more, there is in complex fibroadenoma a DCIS around in the periphery of the fibroadenoma. So it is very important.
He told a very important word. In older women, all this, what I talked, are in younger women. A woman after 50 or after menopause is not allowed to have any change in the mammogram or in the ultrasound. It may appear as benign as you may think. The nicest thing which you see for the first time in menopause or after menopause is cancer, unless you have proven otherwise. So this all is for reproductive age. If you have a nice smooth tumor with parallel to the skin orientation, with nice margins, no halo, no vascularization, everything is fine, but it is in a lady 55-year-old who has her yearly mammograms and her yearly ultrasound, and you see it for the first time, the first diagnosis is cancer. So you do a biopsy. You are only allowed to have this if you are in the reproductive age, not if you are in the menopause. In the menopause, the story is total difference. It is like the previous presentation about B3 lesions. If you have a B3 lesion, in biopsy, you have to operate. If you have a B3 lesion, in the end of the day, you don't have to do anything. So it is totally different if you are reproductive age or if you are in the menopause.
We should never forget that there is 2 type of cancers, the medullary carcinoma and the tubular carcinoma, which have exactly the same aspect in mammography and in ultrasound. And if you don't have a proven by the histology, we can't miss it. I think so.
It is.
Now, I have one question for the first speaker, for Dr. Sinafer Rahman. Is he here? Yeah. Yes. Thank you very much for your nice presentation. I think that you should add in the float chart of the management of papilloma, when you have all the possibilities, to follow up and to discuss if it's not a papilloma complex or not, the dactoscopy with duct lavage and brushing. It is a very new aspect and very new approach to differentiate a simple papilloma to a complex with fibroscopy, dactoscopy, duct lavage. And in Turkey, you have Professor Alsik. She's making this technique. Yeah.
Thank you very much for the presentations, and I would like to ask to Dr. Ferahman. In the third consensus meeting, the recommendations based on open excision or vacuum-assisted biopsy, except for epithelial active generally, the vacuum-assisted biopsy or excision is promoted, and when we carefully dissect the consensus recommendations, almost half of skill consists on vacuum-assisted excision. What is vacuum-assisted excision? Indications, exact, and the limitations, especially in terms of diameter, ATP, or microcalcification. Maybe this is not your question, a radiology question, but as you give the lecture, please.
Thank you for question. I have the same question too, because it's a little bit gray zone. After vacuum-assisted excision or biopsy, except you say flat epithelial ATP, except the other beta lesion, we use generally open excision. We make open excision, but it depends on where you live in. If you are living in US, open excision is more useful, but in Europe, the industries push up vacuum-assisted excision. In Turkey, we reach vacuum-assisted excision a little bit hard. Where you work, it depends on where you work, but if the lesion has atypia, after vacuum-assisted excision, I do open excision if the lesion has atypia or a bigger size.
Any other questions from the audience, if any? We have 10 minutes. You have?
I agree with, how is his name? I agree with you totally, and I want to point out more that when you have a papilloma, intraductal papilloma, you could perform a surgery, ductal surgery, by the dactoscopy. That's the technique of Hunerbahn. We use it in my department in Greece, and it is a minimal surgery by dactoscopy after the duct lavage. Yeah?
Mr. Dinas, I recommend for your slides, in one of your slides, for the biopsy, if the lesion is lower than 3 centimeters, the biopsy is required. However, in our clinical practice, for example, for my pathologist, even after a solid lesion bigger than 1 centimeter, my pathologist say we prefer getting a biopsy, corneal biopsy, and my pathologist gives me 3 results: fibroadenoma, fibroepithelial tumor, or benign, maybe benign. If he says a fibroepithelial tumor, even the tumor is diameter is lower than 3 centimeters, even 1 centimeter, we prefer re-excision. We prefer excision of the lesion, because fibroepithelial lesion is maybe a fibroadenoma or phylloides tumor. The pathologist cannot differ by making pathology. So I think not 3 centimeters is something high. We prefer in our clinical practice, if a solid lesion over than 1 centimeter, maybe it's okay to follow up. But nowadays we prefer getting biopsy, and he says if it is fibroepithelial lesion, we prefer removing it. Another comment. Also, we have some cases.
How many percent do you have?
We have some cases.
How many do you send for biopsy? Because if you send too many, there is something, a problem in the clinical practice. If you send too many fibroadenomas. But if you send something which may be suspicious, how many of them, in the end of the day, he has to reevaluate the result based on forming biopsy? Are the final result of the surgical specimen the same he had before or not?
Generally, we have rare cases. We have rare cases. But why we do this? We don't have enough time for cancer, even for cancer patients. So, by doing this equipment, I prefer getting biopsy. If it is benign, I don't remove any fibroadenoma. I just make follow-up.
Okay. Just to make it clear for the younger ones, there are international guidelines. And the international guidelines say with a triple assessment, which is imaging, the most important, you have to have a bias number. And according to this, you have to deal your case. If you have a bias 3, you can follow it up, or you can do a biopsy in 3 cases. When she lives in a remote area and she cannot be put for follow-up, if she is pregnant, which is a total problematic period in life, or if she has anxiety. These are the only 3 reasons somebody with a bias 3 lesion should have a biopsy. Otherwise, you follow the bias 3 biopsy with 6 months intervention for 2 years, and then you have a bias 2 or a bias 4. If you have straight ahead a bias 4A, you should do a biopsy. So actually, before going to what we say and what the pathologist says, it is to know what we have in paper written from the radiological imaging of the woman. This is the most important thing. Because if you have a problem with a biopsy concerning the radiological image, then you have to evaluate the radiological imaging. Because there are guidelines and there is a special pathologist which has a personal opinion. For me, it's totally different. You have to adhere to the guidelines, and the guidelines they are strict. If you have a lesion which is bias 3, you know what you have to do. If it is 1 centimeter or if it's 5 centimeters, it is a bias 3 lesion. And bias 3 lesion with fibroadenomas, if it is a hamartoma, if it is whatever, it is a bias 3 lesion. So bias 3 lesion have a flow chart. So these were bias 3 lesion, and if they are bias 3 lesion, you need to do what is written in the Do you say the same thing or not?
In the past, our radiologists say this is a fibroadenoma on sonography reports. Now they say a solid lesion, approximately 2 centimeters. A solid lesion. What is fibroadenoma fluid tumor?
Usually radiologists, I hate radiologists, I'm sorry, I don't know if somebody is here. I hate them, I'm a gynecologist. MRI of the pelvis is a disaster. She knows a disaster. If you have, from me, radiologists, I want only two words, sorry. Only 2 words. What is the ACR of the breast, ABCD, how dense is the breast, and what bias it is. I don't want descriptions. I don't want it looks like this, and suddenly we are up at the moonlight, and beside this, a little bit behind, and left to the lesion. I don't want this. I want these 2 numbers. Yes. ACR in mammography, and bias in mammography and ultrasound. I am the clinician, I will decide. If a radiologist cannot do that, he needs to study that.
We have many brass 0 reports nowadays.
This is a problem we have in Greece. This is also why I hate radiologists. Because they do not know to come to a conclusion, and they say bias 0, inconclusive to ultrasound, do MRI, and after they've done all the 3, clinical assessment or clinical follow-up. It is the same. It is the same. There are many types of problems. Radiologists are special types. Maybe I'm also a special type. I don't know, but I the reason, Bahadur knows, that why we established in our department, we do it all of our own. We are not allowed by law to do mammography, but all ultrasound biopsy scripts, everything, all of them. The ones expanded, some months ago, there was there, you were there. We do it because we know how to do it, and we know, and at the end of the day, all the one engaged, very stellar, all of cycles, everybody, in the end of the day, they need also informal assessment, because if you have, I don't know how many percent viral zero, you are not able, you should not be able to do mammography or ultrasound. Viral zero should be very, very minimal. Very, very minimal. You have another question?
No. So, yeah. Yes, the only thing I have one comment is I think very important for two concerns. The first is that with the biopsy we never have the margins. And that's the point. When for borderline lesion we don't know the margins as are clean or not. And the other point, I don't know if there is some pathologists here, but you know maybe that the difference between atypical hyperplasia, which is a benign lesion, and DCIS, which early breast cancer, it's only a question of millimeter. The same lesion, 2 millimeter is hyperplasia, 2.1 millimeter is DCIS. So it depends very much of the pathologist. And there is about 20 to 30% discordance between the diagnosis of the pathologist. So we have to be very careful with the borderline lesion.
Okay, thank you very much. So we don't have a break now. We'll go straight to this young investigator sessions. We have 4 distinguished scientists who will be presenting their presentations. And I would like to invite the chairs of this session, again, Professor Konstantinos Dinas and Professor Zafer Utkan, to run this session and moderate this session. And after each presentation, we will be just, hearing the questions from you. So we will not wait until the end of the session to hear your questions. So you can be free to ask your questions, but we want a brief, questions and brief answers to each one of them. Okay, floor is yours, Kostas and Professor Utkan.
Hello. There is no coffee break. It will be after that. On behalf of my coach, you are welcome in this session. So this is something very, very important for me personally. I always have a very. This is actually the scope of all my academic career. It is the young investigations, the young doctors. This is what we are here for. Otherwise, we will do something else. So I read the program, and there are some very, very interesting presentation. And the first of one, it is Denise Healy. It is the number 1 outcome of best B3 lesions. So all these equivocal ones, a single center retrospective study. Dr. Healy.
Good morning, everyone. Thank you for this invitation. I'm Denise. I'm a surgical trainee from Malta. And today I will be presenting our study about the outcome of breast B3 lesions in a single center, and it was a retrospective study. First of all, Malta is an island in the Mediterranean, and we have the population of just over 500,000, and we have one national hospital. So all the major investigations and procedures are all performed within one hospital. And that means that our data, our study is a realistic reflection of the entire population of our nation. We have one breast unit composed of 5 specialist surgeons, breast surgeons, 3 oncologists, excellent breast care nurses. We have also a breast physician, pathologist, and radiologist. And all these specialists form part of our MDT, the multidisciplinary team. We also have a national screening program where all females between the ages of 50 and 70 years are invited every 2 years to perform a mammogram. That means that our detection rates of breast diseases are very early, and hence the long-term outcome of breast disease has been excellent, some of the best in Europe. We have up to 500 new cases of breast cancers per year, so it has been a very busy unit. So, what is the B classification? The B classification is a pathological classification of breast tissue, usually biopsies taken either as part of the triple assessment or else in view of changes noted on imaging, either on the screening imaging or else as opportunistic imaging. It is a classification that was founded in the UK. It has been used for over 50 years, and it is basically a classification between B1 and B5. So B1 represents normal cellular architecture of breast tissue, while B5 is usually the presence of malignant breast cells. B3 falls somewhere in between. They are described as lesions of uncertain malignant potential, and thus they impose a challenge to design the best management forward for each patient. These are some examples of B3 lesions, as previous speakers have described before me. So we have papillomas, lobular neoplasias, atypical intraductal epithelial proliferations, and all of these cases are discussed in our MDT, a meeting which happens once a week. So what was the aim of our study? The aim of our study was to evaluate our numbers and how are we managing these B3 lesions, and also to analyze the rate of histological upstaging of these lesions. The method. So it was a 1-year retrospective study. We collected data over the year of 2025 between January and December. All candidates were female candidates above the age of 18 years, and they all had to have a B3 diagnostic pathology on the initial biopsy. We had a total of 83 patients, so 83 diagnoses of B3 lesions, with a median age of 52. The biopsies were either core biopsies, the majority were core biopsies up to 80%, and some of them were vacuum-assisted biopsies, 20% of them performed by our specialist radiologists. And then we looked at the initial results. Up to 35% of them were papillomas, so by far papilloma lesions are the commonest B3 findings. And we also noted to have flat epithelial atypia and radial scars, which are also some of the commonest results. So as we said, each case was discussed at the MDT, and the management plan was designed. Some patients were offered follow-up, so that is active surveillance, usually including yearly mammograms and ultrasounds, while other patients were offered excision. So this could be either vacuum-assisted excision performed by our radiologists. We had up to 23%, and 45% of our patients underwent surgical excision under general anesthesia by our breast specialist surgeons. The result of each was, of course, noted. So out of our total of 83 patients, 57 of them underwent excision, either surgical or vacuum-assisted, and 10 of these had resulted into upstage histology. That means that 17.5% of the B3 lesions that were excised showed histology, either evidence of the CIS and pre-malignant disease, or indeed the presence of cancerous cells. As we said, so 10 patients had the presence of upstaging, 8 of them being low to intermediate the CIS, and 2 of them having invasive cancer. So this is a table where we tried to find the correlation between the initial B3 histology and the final upstaging histology. Papilloma was noted to have the highest rate of upstaging, but also ADH and AIEPs had a significant rate of possibility of upstaging. In this forest plot, we can see that we analyzed risk factors of who are the patients that have the higher risk, where their B3 lesion has a risk of becoming something more serious. Age was the most significant risk factor, so obviously the older the patient, the higher the risk factor of developing upstage disease. Also, as shown in the previous slide, the presence of IEPs and ADH was also a significant risk factor when calculated on our forest plots. So, in conclusion, the upstaging rate of our study of the B3 lesions was up to 17.5%, which is very similar to what is found in international studies and literature. Why is this study important? It will help us to make future decisions in our MDTs to be more informed and more of an informed decision. And also, perhaps it will give us ideas to perform other studies. First of all, perhaps we can perform prospective studies to closely document and evaluate what is happening to our B3 lesions, and also to see what is happening to those cases that are subjected to surveillance. So if the initial B3 lesion is not excised, what is happening, let's say, in the next 5-10 years? Is there any change in their imaging? Do they need rebiopsy? Or perhaps the outcome of the MDT changes and they will be later on subjected to some sort of excision. So thank you for attending this presentation. We are very proud to be collaborating with our Turkish colleagues. Our history runs much deeper than you would assume. Also, I would like to invite you all. This was our conference last October, but I would like to invite you all for our breast cancer conference in October of next year, where you can obviously have further discussions with us and also enjoy our beautiful country. Thank you.
Thank you, Dr. Hill. Second author, Merve, question, please. The subject is endoscopic versus open gynecomastia surgery, multi-center retrospective comparison and aesthetic outcome, patient satisfaction and nipple areolar complex sensation. Please, Merve.
Hello. Hi, I'm Merve Tokucun. Good morning, everyone. Thank you for being here. Today I will present our multi-center retrospective study comparing endoscopic and open gynecomastia surgery. In this study, we focused on aesthetic outcomes, patient satisfaction, and nipple areolar complex sensation, and pain and complications. In this study, we have 55 patients from 2 tertiary centers. Let's begin. As we know, gynecomastia is the most common benign disease for men. It affects both physical appearance and physical social well-being. Many patients experience embarrassment, social anxiety, and low self-confidence. Medical treatment can be helped, but after fibrosis tissue, the surgery is the most common options for treatment. But open surgery is still as a standard approach, but the standard approach, and endoscopic is and the endoscopic one is the other option. Because of limited comparative data in this literature, we want to compare the two approaches in details. We designed that study as retrospectively as two centers, and patients just include Simon grade 2 and 3. The endoscopic group includes 25 patients and 49 breaths, and the technique is we use the small incision, rigid endoscope, and Smithson infiltration. And the second group is open to 1, and 30 patients is in there, and 58 breaths include that group. In this technique, we use perioral or infraareolar incision, direct excision, and standard electrocochlear dissection. Our primary outcomes are pain, knock sensation, aesthetic score, breath Q satisfaction scala, complications, and is there any necessary for revision surgery. And that's the incision that we made in endoscopic surgery, as you can see on the mid-axillary line. First, the two groups were statistically similar. There is no significant difference in age or Simon grade or body mass index or smoking or alcohol. But when we look at the operative findings, endoscopic procedure took a little bit longer time as the open one. But incision size is much more smaller, blood loss was lower, hospital stays was shorter, and the specimen weights were similar between groups. That means the minimal invasive approach did not reduce surgical competence. And when we when we look at this figure, the pain is lower in endoscopic group. At the 12 months, endoscopic groups were completely pain-free, and we believe these benefits related to soft tissue trauma, lower incision size, and less flap elevation. And most important finding is aesthetic superiority of the endoscopic approach in this study, we guess. As a surgeon rated scores, significantly better in endoscopic one. And the scar quality was also better in the endoscopic group, because this is expected one because the scar is hidden. So patients reported satisfaction with breast Q chest module. It has 12 points between groups. This is important because exists the minimal clinical important difference is important. It's really meaningful in this statistical results. There's only not a statistical significance. It's also meaningful patients in daily life. As a most important, this slide shows knock sensation, and both groups had decreased at 6 months. This probably related to post-operative ödem or neuropraxia, but at 12 months, endoscopic groups recovered much better than the open group. Clinically significant hypoesthesia was only in 16% in endoscopic group and 62% in the open group. This is maybe because of the axillary approach is better preserves lateral intercostal nerve branch. You guess that. And there is no numerically significant statistical difference between the groups, but there is more seroma and more ECMOs in the open group. There is no reoperation or no recurrence in the both groups. The important findings was sensory and patient satisfaction and less pain, better scar looks, and the only disadvantage was a longer operative time in the endoscopic group. The difference was around 6 minutes. Of course, we have limitations. This is retrospective and just a few patients we have. In conclude, there is less pain in open, there is less pain in endoscopic group, smaller scar, lower blood loss, better nipple sensation, and better scar quality and higher patient satisfaction. And if it's possible, this technique may become an option for selected patients. And because even a pearl acidic choice can reshape destiny, just like the golden apple of Farklı. Thank you.
Thank you so much. Are there questions from the audience?
No. No.
No questions? Can I make a comment? A small one?
No.
No. You see that 10% are not satisfied whatever you do it. If you do it open, if you do it laparoscopic, endoscopic, they're not satisfied. So these 10% are everywhere in life, you know. Thank you so much. So we proceed with the next presentation. Yes, I need my glasses. Yes, exactly. It's paper number 3, pure atypical ductal hyperplasia on breast biopsy. Yes, upgrade rates, risk factors, long-term outcomes. Adnan Gündonglu.
Good morning, everyone. Thank you for the opportunity to present our study. Today, I will present our findings on pure atypical ductal hyperplasia diagnosed on breast biopsy. We analyzed the upgrade rates, risk factors, and the long-term outcomes in cohorts of 251 patients. This is a collaborative work with Dr. Gentile and Professor Corrado Tunteri from University, Italy. When we encounter pure ADH on core biopsy, the key clinical questions: should we excise or can we safely observe? Our study had 3 main objectives. First, to determine how often pure ADH upgrades to malignancy after surgical excision. Second, to identify which factor predicts that upgrade. And the third, to evaluate the long-term oncological outcome of these patients. This was a descriptive retrospective cohort study including 251 patients with a pure ADH on breast biopsy. All patients underwent a surgical excision. About 70% of biopsy were vacuum assisted, and 30% were core needle biopsy. We used logit regression and both univariable and multivariable analysis. And also, importantly, our median follow-up was 9 years, and this gives long-term data. Looking at the demographics, and the median age was 48 years. Nearly 2/3 of the patients were premenopausal. Family history of the breast cancer was present in about 9%, and only 2% had a personal history of breast cancer. Regarding genetic mutations, the vast majority, almost 97%, had no known mutation. Only 2 patients carry BRCA mutation, and 6 had other non-BRCA mutations. Moving to imaging and the biopsy findings, most lesions were non-palpable. At 64%, detected primarily through the mammography and ultrasound. Calcification were seen on 1/3 of the mammogram. Artificial distortion in 12%. On the biopsy vacuum assisted, on the biopsy site, vacuum assisted biopsy was the dominant method at the nearly 70%. The solid pattern was by far the most common historical pattern at 76%. The vast majority of the lesions were unifocal. Sorry. Now, here are our key surgical findings. And this is the central result of our study. The overall upgrade was 4.8%. This was evenly split. 6 cases of invasive carcinoma, all non-specific type and luminal light. And also 6 cases of ductal carcinoma in situ. Sentinel lymph node biopsy was performed in 10% of cases. On univariable analysis, 4 variables reached statistical significance: age, 50 and older, postmenopausal status, genetic mutation, previous breast cancer history. On multivariable analysis, genetic mutation emerged as the only independent predictor of the upgrade, and also postmenopausal status shows a trend, but didn't reach significance. So, to summarize our study, the upgrade rate from A to H is low at 4.8%. Genetic mutation is the only independent risk factor we identified for upgrade. And age over 50 and more, postmenopausal status and the previous breast cancer were also significant on univariable analysis. Our long-term data with our 9 years of follow-up shows a very low recurrence rate, only 0.8%. So, for the patient with pure ADH and no genetic mutations, close surveillance may be a safe and reasonable alternative to routine excision. Thank you.
Take the last. Okay. Please. Yes.
12 years ago, the situation was
in your practice, right?
Probably this is humanitas. This is why they have this low rate. If it was a general hospital, they would upgrade it a lot, but they have a good diagnosis beforehand. This is why they upgrade in a lesser situation.
Right.
One, two.
Is there any question?
They are having also at higher risk women with typical included hyperplasia, typically hyperplasia. They include also a prevention treatment with tamoxifen or exemestane. So did you check also in your study with these well-validated questionnaires and risk assessment tools before waiting 12 years? Because you follow up 12 years, so if you would have applied at the basis these calculated risk, maybe these women may get, in Europe we are not giving tamoxifen, but maybe you will get some other surveillance. Thank you.
Yeah. We don't use any calculator. That's only a retrospective study because of, yes, because we don't have any chance to use any tool, actually. No. Yes, maybe, right.
Yes, please.
Thank you very much. In our experience, we are on the way to publish. It's about 8 to 10%. Anyway, I agree with everything that you show us, and congratulations. My concern is that 5% in statistics is not low, it's high. And because when you also do everything for hormonal receptor, when it's 5%, it's positive. When you make a study and you have P005, it's significant. And 5% to 10% depends, it's 1 of 10 of 1 of 20 patients. It's not nothing. I concern very much about 5%. If it was 1 or 2%, okay, but 5% to 10%, it's not zero.
Right. You did very well.
Thank you. Just young.
May I ask a first presentation?
The lady from Malta, yes?
As far as I understand, vacuum, therapeutic vacuum does not guarantee negative surgical margin if the lesion upgrades to malignant. In the first presentation, the therapeutic vacuum rate almost 33%. Did you see any malign upgrade in after therapeutic vacuum biopsy?
The question again, please.
So, I mean, the patient B3 lesions, 32.5% underwent vacuum-assisted biopsy. Is there any patient among the vacuum-assisted biopsies? Have you ever seen malignant conditions? Because negative margins, it's impossible after vacuum.
Yes, we did have some results of upstaging.
What did you do after?
We provided a wide local excision, and on the histology there was evidence of invasive malignancy accompanied by sentinel lymph node biopsies. So an oncological resection, essentially.
Yes. The last young investigator is Georgia. Marjorie, George. Topic. Clinic epidemiologic characteristic of breast fibrilloma and differences between surgical and conservative management. A single center core study. Please, Georgia.
Esteemed chairs of the session, dear professors and colleagues, good morning. So on behalf of my department, the second department of obstetrics and gynecology from Thessaloniki, alongside, of course, my professor and mentor, Konstantinos Zinas, I'm going to present a cohort study, a retrospective one, that we did regarding the clinical, epidemiological, and histopathological characteristics of all women treated for breast fibroadenomas in our clinic. So, as it has been underlined in the previous presentations, of course, breast fibroadenoma is the most common benign disease that we find in the breast, especially young women, and the management may vary. There is a great spectrum, as Professor Dinas told us already. So we can either go from totally conservative management with surveillance to, of course, surgical excision, and there are many factors that we should weigh in during this decision that we should make about our patient. However, histopathological confirmation of the fibroadenoma is not always an easy case. There are some tricky cases, especially when we have histological overlap with phyllodes tumor, and this may pose challenges to the management. And of course, having a better understanding, a deeper understanding of some clinical epidemiological variables regarding the profile of the fibroadenomas, this may help us choose the correct therapeutic pathway, of course. So, the aim of our study was to evaluate the main clinical, hormonal, epidemiological, and histopathological characteristics of the women that we treated with fibroadenomas in our clinic, and then we attempted to do a comparison for the majority of those variables between patients that we treated with surveillance and patients that we treated surgically. So, it was a 2-year retrospective cohort study. It was conducted in our department, as I already told before, and we included all teenage and adult women that had histologically confirmed fibroadenoma. We have already done a core biopsy to confirm it, and the majority of women, they underwent the CNB due to enrollment in an academic educational protocol that we have in our clinic regarding CNB. And of course, we included patients that were either treated with conservative management or patients that they received surgery, surgical excision of the lesion. We collected our data regarding the main epidemiological, clinical, and histopathological, as well as variables regarding hormonal exposure for these women. And then we attempted, as I already told, a comparison for the main variables that we collected and analyzed. And then we proceeded to take a greater look in our surgically managed cases, and we analyzed the indication of the surgery. We saw the lesion size dynamics for the patients that we have a follow-up period about, and of course, we did a concordance regarding the pre-operative and the post-operative histopathological report that we got for the women that were operated on. And we performed our statistical analysis with the SPSS software using proper non-parametric and parametric statistical tests. So, proceeding to the results, we had 106 women with histopathologically confirmed fibroadenoma through core biopsy in our department for this time of period that the study was conducted. The main age at diagnosis was 33.5 years, and the median, to be more correct, BMI was slightly over 25. So the majority of women were just a little bit overweight. And about a quarter of them, they had a family history of fibroadenoma regarding their first and second degree relatives. Proceeding on to the hormonal and reproductive profile of the women, the median menarche age was 12 years of age, almost just a little bit upper from the 0.5%. The women, they were nulliparous. And for those that have children, the majority of them had 2 children, and the age of first delivery was at 25 years of age. Just a small fraction of the patients were postmenopausal. The majority of them, as expected, were premenopausal, and just 12 patients, so 11% of our patients, used oral contraceptives. And proceeding to the actual characteristics of the lesion, the median size at diagnosis was 14 millimeters. The majority of patients, almost 8% of our patients, had just one lesion, one fibroadenoma. And 22% of our patients, they complained of persistent symptoms that they were not well tolerated with conservative management. And the main symptom that women were concerned about was, of course, mastalgia. Of those 106 patients, 38 of them saw almost 36% of our cohort underwent surgical excision of the lesion that was identified as fibroadenoma. And proceeding on to the direct comparisons regarding the majority of the variables that we have already discussed between patients receiving conservative and surgical treatment, as you can see, and I'm going to summarize that, we did not have statistically significant differences regarding the majority of the epidemiological and the hormonal factors that could weigh in and that could potentially play a role in the formation of fibroadenomas, namely the BMI, the family history, the age of menarche, the parity, and the age of first delivery, as well as the menopausal status. However, we find differences in 3 of the variables that we examined. So, as expected, the women that were treated surgically had a bigger size of lesion at the time of diagnosis, and this was statistically significant, but this is mostly anticipated, since the size is one of the factors that we take into consideration in order to decide for surgical excision. But however, we had a slightly unexpected result. So the women that they underwent surgical excision, they were more frequent users of oral contraceptives. And we're going to discuss that a little bit later. However, the population, as I already told, that was using oral contraceptives was very small, only 12 patients out of our cohort. And finally, as also anticipated, women that underwent surgical treatment, they had persistent symptoms that were affecting the quality of life. This was more frequent, of course, in the patients that received surgery, and this was statistically significant, as you can see. So regarding our cohort, the main features and variables that they were associated with eventual surgical management was the size of the lesion at the time of diagnosis, the presence of persistent symptoms, and the use of oral contraceptives. And let's dive into a little bit more at the patients that received surgical management. Why did they receive that management? So for the majority of cases, the indications were those 3. They, as you can see, combined that surpassed the 50% of the cohort. So the size at diagnosis, the presence of persistent symptoms, and the rapid increase in size during follow-up were the main reasons that we operated on these women. And regarding the size, because it's something quite ambiguous, as Professor Dinas already told us, not all guidelines are aligned on that. When we performed surgery at these women, the majority, the median, just to be correct, size of surgery was 20 millimeters, but this includes all the patients for all the indications that we performed surgery on. But if we just minimize, if we just make a little smaller of the population that received surgical treatment and see the women that were excised due to size or rapid increase, then the median size at surgery was 36 millimeters, so it was significantly higher. And if we want to see what did we consider a rapid increase, because this is also not something well documented in guidelines, regarding only the patients that were operated due to rapid increase, this increase was 20 millimeters in a median follow-up period of 17 months, ranging from 13 to 21 months regarding the follow-up period for those patients. And finally, the final histopathological report that we received were consistent and concordant with the one that we received preoperatively through the core biopsy for the majority of cases. But there were 6 cases that we had discordance between the preoperative pathological report from the core biopsy and the postoperative final histopathological report after surgical excision. And the final diagnosis for these 6 patients that initially received the diagnosis of a simple fibroadenoma was what you see right now on the slide. So we had 3 patients that were eventually diagnosed with complex fibroadenomas and 3 patients that were eventually diagnosed with benign phylloides tumor. And the indications for the surgery at these cases were not, of course, only the uncertainty after the core biopsy. As you can see, this was only the case for one woman that was finally diagnosed with complex fibroadenoma. We also performed surgery at these cases of disconcordance due to size of diagnosis, due to radio and pathological discordance, and of course, regarding especially phylloides tumor, as expected, the rapid increase in size. So let's see what the literature says about the statistically significant results that we had in our study. As I pinpointed before, the result regarding the use of oral contraceptives was not expected because it's not aligned with what we know. And we have a lot of data that shows that actually the use of oral contraceptives, especially those containing estrogens, but we have increasing data also about those containing only progestins, so that they have actually a protective effect for the development of the fibroadenomas. So what we had was not expected. However, I find just one study, a big Swedish cohort study with almost 60,000 patients, where just a small fraction of those 60,000 patients, that's 45 patients actually, no, 54 patients, they developed breast cancer after being diagnosed with fibroadenoma, not on the same lesion, a subsequent breast cancer. And for this very small percentage of the patient, the use of oral contraceptives was found to be a risk actually for development of subsequent breast cancer. However, in our cohort, we mainly attribute this result, of course, to the very young age of the women that used oral contraceptives. In their vast majority, they were below 30 years of age. So it's a subpopulation that more usually uses oral contraceptives. And of course, we had a very small subpopulation using oral contraceptives, just 12 patients out of 106. Regarding our other significant results, of course, they are anticipated. We know that for the majority of the cases, however, taking into consideration other factors, a size above 3 centimeters is usually an indication for excision. And of course, when we have a persistent symptomatic fibroadenoma, this is a sole indication that can be accepted when it affects greatly the quality of life of the woman. And finally, our upgrade rate. It's not usual to have a high upgrade rate from fibroadenoma when we have a preoperative histological diagnosis to phyllodes tumor. So I found a cohort of 112 patients that had an upgrade rate of 9%, but the upgrade rate was mainly distributed in patients that have big fibroadenomas, initially diagnosed lesions as fibroadenomas, that they were older, and that they had a high radiological suspicion of having something more than fibroadenoma. But when we receive a preoperative diagnosis of a fibroepithelial tumor, not a fibroadenoma, then the upgrade rate is greater. And according to a study from 2017, in the American Journal of Surgery, it may reach 37.5%. So when we have ambiguous results or when we're not sure regarding the histopathological report, of course, a consultation from an expert, from an experienced pathologist, may lead us to a most correct therapeutic approach. So to conclude, of course, we know, and there is a lot of studies, epidemiological studies focusing on that path, that there are various epidemiological features and clinical ones that could be affecting the progression of fibroadenoma. And usually the clinical features is those that lead us to the surgical management. In our cohort, persistent symptoms and increased size of diagnosis were one of the main significant differences between the two groups regarding the approach that we followed, alongside the paradox result of the use of oral contraceptives. Of course, main indications for surgical management is the increased size, the rapid increase size during follow-up period, and the presence of persistent symptoms. And when we have a preoperative pathological report, however, when indicated to do a core biopsy, this leads us to lower upgrade scores. But in any case of ambiguous results, of course, the expert opinion of a pathologist that is experienced in that kind of lesions may provide us a more accurate result. Thank you very much for your attention.
Thank you very much. Perfect. Is there any comment?
Actually, my question is directly to Dr. Dinas. In my practice, I prefer to remove surgically all palpable fibroadenomas because it provides me both diagnostic and therapeutic. And my person, but a certain amount of the patients, for example, more than one fibroadenoma is available, fibroadenomatosis. And if other ones non-palpable, I keep them
under observation. I would like to have your comments.
Regarding if a fibroadenoma is palpable or not, it does not have to do with the pathology of the lesion. It has to do with the level of the breast regarding to the skin it is. If it is more superficial, it is palpable. And if you have a size a cup A or B, it's more easily palpable. If it is in the lower third and you have a cup C or D, it's not palpable. And from all the data we have, we know that there is no special area in the breast which is more, let's say, prone to have a malignancy or to have a degeneration or anything of a lesion regarding its location. So for us, location plays only a role if they cause a visual discomfort, if it is very big and very superficial, just under the skin lining, and it causes that discomfort because it is visible or the boyfriend, the husband, the partner does not feel it. It's only a part of location for us, and from the data as far as I know, location does not play any role in the management of a lesion.
So, thank you and well done for your amazing presentation. Few comments about my practice and our population, because we have different, obviously, cultures and levels of anxieties. I think when we have a virus 3 lesion or a new fibroadenoma, and it's reported as virus 3, our radiologists, rightly so, they report it as virus 3, and we offer both follow-up and biopsy. And most women nearly exclusively choose biopsy because, according to your practice, 2 years of follow-up every 6 months, it is associated with most of our patients with a level of anxiety which they cannot tolerate. Besides being, in my mind, difficult to justify if there is, after 2 years, a diagnosis of a cancer. Because then medically, how can you answer that question? So you missed my cancer for 2 years. We could blame the radiologist, we could blame the team, but at the end of the day, the patient will complain that you left a lesion for 2 years. So our patients like to have a biopsy, and if it is benign fibroadenoma, they don't usually want it excised because they trust the pathologist, they trust us, and they don't, I mean, this issue of pre-menstrual period, discomfort, and so I think it's partly associated with anxiety. So, your comments about,
I can totally understand that there has to be some local, regional adaptations or changes to the guidelines. But in the end of the day, guidelines are guidelines. There are strict guidelines about a lesion. First of all, let's stick to the guidelines. Before surgery, you need a biopsy. I think there is nobody here in this room who goes straight ahead to surgery, even if he is more than 100% sure that's fibroadenoma. Nobody ever makes a surgery before a biopsy, without a biopsy. We are 100% sure about this? Everybody, yes? So you do a biopsy. If you do a biopsy and you have a benign lesion, in the European Union we have some guidelines regarding the data you must have being a certified breast cancer center. So you cannot, the surgery of non-cancerous lesions should be limited in less than 10%. These are our guidelines. So I cannot operate in the state system in a cancer center, not cancer, because the other one is anxious. It all depends how you inform patients. There is biased information. It's the most easy things to do. If you just don't talk and just say one like this, it's done. The patient is fearful. So you have to stick to the guidelines, and if you stick to the guidelines, you can stand also in front of the court, yes, because this is life. We do not operate because can you imagine if you have a benign diagnosis on biopsy and you proceed to an operation and then she cuts a bag in the hospital, you know, a hospital bag, which could lead, there is a presentation here, somebody to necrotizing fasciitis or a rest like this. How will you justify it? Then you must be absolutely sure that she will tell the lawyer that I didn't have the right information for the surgery. I thought they didn't explain to me that it was such a minimal possibility to be something. Nobody. Do we know that an earthquake will not do now and everything of this will fall us apart? Is it 1 to 10 the possibility? Is it 1 to 1 million? So actually when you have a benign histology, a really benign histology on biopsy, we are not justified in our state system to do it. If you won't take the lady, do it privately. In the private office, you can do whatever you want, but not in the same system.
No, we are in agreement completely. I'm not, actually, we nearly never, if not never, operate benign fibroepithelial tumors without complexity more than 4. My only issue, and our patient's only issue, is not having a biopsy diagnosis. So relying solely on a BIRES classification. Because BIRES 3 is less than 2%, but 2% is significant as well.
Well, this is the most important
So
development.
with a biopsy, we never operate.
Yes, but this is a development in imaging over the years that we can communicate. If now we take under discussion that a BIRATS 3 is not a BIRATS 3 and it's a BIRATS 4A or it's a BIRATS 2, then the whole system of radiological imaging and classification disappears. A system has to rely in each of its parts. You need to have a radiologist which gives you a precise diagnosis. This is the reason I hate this specialty.
But again, they have a difficult job, Professor.
No. They don't have a difficult job. I'm sorry about this. No, I'm not a trained radiographer, and I know that my trainees, they are much better than the average radiologist in breast ultrasound because we don't do mammography. No, it's just a matter of training.
Most of us will do an ultrasound, but they will not commit themselves whether it's a fibroadenoma or not on ultrasound.
Yes, I must tell you that when I started the breast unit 15 years ago, this is my personal, I bought an ultrasound with a linear probe and I did breast ultrasound and biopsies, and the radiologists were asking what is he doing up there in the 4th floor. It is a reality. And then she is here, they came to us and we learned the biologists, the radiologists to do breast ultrasound, to take biopsies, to put clips. They didn't know it. We gynecologists, and we're not even surgeons, we're gynecologists, and we learn them how to do it. So it's just a matter of practice. If somebody sits like the 3 previous one here, who sits in the night and study as residents, and they do it, they can do it. I don't know how it is here, but in Greece we have a very big problem with imaging. It is a disaster. Sorry, yes. We can discuss later. Now there is lunch break.
Okay, no, not much.
No, not lunch.
Before that, thank you very much for all the speakers so far. Now, this is not a pre-planned thing. Now, we have a ceremony because we encourage these young investigators to come here and give their talks. So there was a hidden jury members in the audience, and we asked them to rate these 4 presentations. So, and I asked them to give us their results and decisions so we can present the best paper award to one of those 4 speakers. So I would like to ask the jury members, the speaker, have you received the decision? The microphone? Yeah. This is a surprise. It's not written anywhere.
Yes, thank you. Thank you for choosing us for juries, but we understand why you choose us, because it's very hard.
It was a random thing, you know, it should be random, you know.
It's a hard job, because we have 4 excellent and excellent and...
Can I have
Okay. Okay. We have... Okay.
Let me see the results first. something, you know, in a good way. All right. So, let me read it. Need to put my glasses. All right. Oh, surprise. So, thank you very much for the decision here. So, we had 3 jury members, and the best paper goes to all 4. Thank you very much. So I would like to ask, I mean, this is a very difficult decision. So how did you come to this decision, Sina?
We have 4 experts and available presentations. Because of this, we choose 4 winners.
Right.
Thank you
okay.
for, thank you. Thank you for
That
all,
was difficult for you to
yes,
choose
yes.
one. Okay, here is the decision, so you can read it, okay? It's not a blank page. All right, I would like to invite first Professor Can Türk as the convener, and also Kostas, please, Konstantinos Dinas, and also Stefanos Zervoudis as our past president in the society, and Professor Utkan as the chair, and also our past dean for the faculty, to give the, awards. No, I'm the speaker here, So that's why I'm here still. Oh, thank you very much. So I would like to first invite Dennis, the first speaker, the first presenter. Come here. So welcome. Okay, Dennis, you can stand here, just beside me. I would like to invite the second presenter, Merve Tokocin. And so, and the third presenter, Adnan Gündoğdu, and Stefanos. So you may do the certificate and the present, the award. Okay, Adnan, come here, please. And the last presenter, Georgia, please. Yeah. And Professor Utkan will give the award. Now we can have a photograph all together, please. Now I'm enjoying you. So this is the end of this session. So we will be going to lunch. The lunch is served where? Yemek nerede? Please follow the sign or the guide, to the lunch. Did you like the surprise?
we will discuss in this session benign inflammatory breast disease. I would like to invite the first speaker, Dr. Juliana Chelchu, please, for her speech. Title is Lactational Mastitis. Where is it? Lactational mastitis, etiology and management. Please.
Thank you very much. I'm very happy to be here today, and I want to thank Dr. Bahadir and to university organizers for the opportunity to speak here about one of the most common and, as you will see, also most untreated pathology of the breast from the ancient times. It is lactational mastitis. Dr. Bahadir was very generous to give me this very feminine subject, because he knows that I'm okay. I hope that will go on. I have now a disclosure related to this subject. It is not going on, but I can speak even without slides. Okay, now it's okay. I have no disclosures related to these subjects, and I think that I will try to get this overview of the lactation mechanism, treatment in the vision of the new guidelines, because even the pathology is very old. There are many pitfalls around the world related to the attitude in lactation mastitis, and I think that you should put the first one, because this is a rare pathology. The people from they put the second presentation. They put the rare condition of. Anyhow, we will start related with the. Can you put the other presentation, the first one? You put the second one. It's okay. When you have two, the mistakes can easily be done, but it's normal to start with mastitis. Lactational mastitis is getting around 10% of all the women who are delivering all over the world. So the incidence, as you know, as a social problem, in the definition of the government, it means to get more than 10% of one patho of the people who may address this pathology. So lactational mastitis is a social problem because it is the first cause. This is the good one. So it is the first reason for decreased breastfeeding, and then allergy problems, together with the program Wednesday morning C-section. So these are the two pathologies that they decrease the breastfeeding in the world. And I will try to get these problems in this presentation. So actually, when it's happening, the lactation mastitis, it is in the first 3 months with large variation in and will get 10% of the population. With large variation, you see that it is between reported like 1 to 33%. The countries like Canada and UK, who have a community assessment of the woman in the lactation period, they are reporting more correctly the incidence of the lactation, and the highest proportion is reported in Australia, where they have large regions, more larger than whole Turkey, which is a very large country, they are tied only on community services. They have 1 or 2 doctors assess 1 month regarding the lactation problems, and they are reporting lactation mastitis till 6 months. But the most common it is in the first 3 months, and of course in the first 2 months is very important because it is important to continue the breastfeeding. The most important risk, it is done in the first days when the lactation is not installed, mostly, as I've told you, in the Wednesday morning program C-section. So they are, even if it is over 39 weeks of gestation, so let's say it is a term, we are not talking about the programming at 38, which is tied to special indication, medical indication. The other problem is the attaching of the babies, the babies who are premature, or the babies who are not adapted to the nipple. So the nipple has, it is not formed mostly in primipara, but also in the secundipara if the baby has an adaptation syndrome, so it has not enough tonus, and it is not proper, it's not breathing very well. In women with big breasts, let's say the attachment, this poor latch, actually it is called the attachment. And of course it is related also with the mothers who have tight clothes, the mother who don't want to lactate, or also with prior mastitis and they are getting afraid of the mastitis. Actually, in 2026, we are not treating lactation of mastitis as a disease. It is a continuum as we are trying now to communicate with our students. It is a spectrum of a disease. It is going through the inflammation and the old term plug duct, that it is actually not related to the content of the ductus. It is related with what's happening outside of the ductus, and they compress the inflammation. It is outside of the ductus and they are compressed. And the first 2 stages with ductal mastitis, which is coming on the duct but from outside, and inflammatory mastitis, which are the terms related to underlying pathologies. These are the first 24-48 hours in which we should not address as a bacterial infection. The next steps, they might get bacterial infection, but 70% of the mastitis, they are limited themselves by continuing the lactation and by adding simple inflammatory, anti-inflammatory drugs and local treatment. As you will see, the installation of the lactation in the 2nd day or in the 3rd day, which is not immediately, it is depending on the way you are putting the baby on the breast. That's why the breastfeeding is very important to get the baby, no matter of the moment of the mother, even in the 1,000 grams babies at 28 weeks of gestation, the coming of the baby to the breast mother and will start the lactation actually in the first 1 to 3 hours. Also, the mechanism of hyperlactation applied in the 2nd and the 3rd day, when the lactation it is installed, and also the baby does not need so much milk. The important is not to over pump the milk, because then it will be again constrained and they will get more and more milk, and the baby does not need more than 10 to 20 milliliters. The baby over 4 kilos will need more than 15 milliliters per 1 breastfeeding. That will be every 4 to 6 hours when it is on demand. And of course, when the inflammation starts and the compressing of the ductus, then there will be the stagnation and it will be the risk for bacterial impulse superinfection. The dysbiosis and edema, again, it is a cascade, it is a continuum, and they should be treated. If we only should be treated only with anti-inflammatory and with cold appliance on the breast, not hot. Yes, this is a consensus because there are many, and this is a consensus of the Academy of Breastfeeding together with the NIH and Australian midwives community reports that it should not be applied on the breast hot things. Also, it is another thing for the women in the room and also for the doctors because we are at the basis, most of us, I am an obstetrician and gynecologist. That old thing that you should manipulate the nipple in order to get immediately breastfeeding in the moment when it is when you will deliver, it is not anymore considered suitable because will increase the contractility. Actually, it is a way to stimulate the birth because stimulating the nipple will increase the oxytocin liberation, and then you will get in the pregnancy only contraction. So you can use this as a term as a nipple stimulation to make the birth to come quickly at term, but not anymore for the nipple. And it is dangerous because the scratches in the nipple, then they will be some gates for the most important infections. They are common as a stuff, they are staying on, they are commensals and they are staying on the skin, and they will be the first that they will get the lactation mastitis. The inflammatory spectrum in the clinical, it is without fever and also without tenderness and needs conservative treatment. When you get fever, and here it's very important how you will measure the fever, because when you are putting the hand or the temperature measurement, the thermometer in front, they will measure the temperature of the breast, not the general fever. So the thermometer should be put on the back of the subclavian part. And of course, the fever and it is a sign of superinfection. I think that here in Turkey and also we in Europe, together with this large migration, we are seeing more and more women with non-white dermal color. And in these women, sometimes it's very difficult to distinguish the reddish, as we can see in the Caucasian women. So take care, in black women, the inflammation exists exactly like in the white women, but the reddish, you should not wait to see the reddish and the skin like in this different color. So the color is not so different in black or darker colors of the skin. When to investigate, of course, any woman with any complaint on the breast and on time of the feeding and with any pain, and I'm telling to my students and to my residents, and when a woman is coming in the lactation period, you have to put one arm on the breast and one arm on the belly, and you will see where it's the fever, where it's more this cold or warm, and it's because during the lactation, in the postpartum, one of the most important and dangerous infection, it is not only breast infections, lactation mastitis, it is also the infection on the uterine part. So fever, even the breasts are red, might be caused by also other causes, so you have always, when it is a fever, to think also about the other causes. Cool compresses, continue breastfeeding, anti-inflammatory status, and also maternal rest and lactation, because it is a continuum between the depression and lactation of mastitis. Sometimes you don't know which was the first, the depression, the really depression in the lactation period and mastitis, or mastitis by itself. Anyhow, no heat, no aggressive massage. It is important to get out the milk from the breast only on the nipple stimulation, not on the whole breast, and also not to have the intention to completely get the milk out of one breast, because this is aggressive and will provide more pain, and it is no effect. Also, it is not evidence that we may use probiotics or prebiotics with probiotics, and also it is not, it was never implied the sterilization of the pump. So never ever, but they have to be cleaned, but not sterile. All the pumps, what should be sterile, they will be the pockets in which you will preserve the milk, but not the pump sterilized. And of course, all the antibiotics in case of fever and suspicion of bacteria, they are compatible with the breastfeeding, and they are new. And the first line in Europe and in United States is dicloxacillin. This is a penicillin, new one, which is important for the staphylococcus with methicillin resistance. So it is the first line, or of course cephalosporin second or third generation, clindamycin, and don't forget the old trimethoprim with sulfatiazole in double dosage, which means that one we usually use for ages 1950, 80 plus 400. This is a double dose with 160 trimethoprim and 800 milligrams 2 times per day to have the proper concentration in the area of clinical mastitis. Of course, the continuum should be at least 7 to 10 days, and it's important related to severity, the level of and the way you are giving the antibiotics. So again, the paradigm shifts. So no empirical antibiotics, so this is not the first line. Don't empty the breast, don't make the massage, increase the lactation by attaching the baby very well. And it is a sort of madness. In France, they give a law. So you need at least 3 doctors to indicate the frenulum cut, because they were in the community said that it is a problem with the tongue related to the attachment, but it is not. So in France it is forbidden to be done, except you get 3 doctors to get an indication, and you are doing in a state unit, not in private. Okay, going to the treatment, it's important to start correctly, to get an assessment. So if you see a woman and you don't know if it is a lactation problem, it is a start of mastitis, you have to see her in 48 hours to decide if it is, and apply the local treatment and non-anti-inflammatory treatment, yes, with conservative care. If in 48 hours it continues, and she continues to breastfeed, yeah, and in 48 hours it's getting the severity, more severity, increase the severity, then you may have the assessment, antibiotics, and evaluate the stages of abscess and phlegmona. There is no more indication of high surgery opening. Actually, the first one, and in NIH and also in NICE in UK, the first part of an abscess, the drainage, it is in the needle aspiration. So it is not anymore a cut with opening. And also in the phlegmonal part, yeah, it is important to minimum the tissue involvement, because then the healing itself, it will become a problem, and it will be followed by retractive tissue and recurrent mastitis. It is involved, and it was reported more often. What is important to get to assess the severity and also the continuity of the process is erythema involving more 1/3 of the breast. The well-known in the surgeon world, the hange, yeah, the skin, the parent, which means also the lymphatic invasion. Yeah. If it is not responding to 14 days, and of course the women that they are older age in postpartum, not immediately in the first 2-3 weeks, that might be more aggressive. And also if there is no pain, it is very important, a mastitis without pain, we should think of biopsy, as you will see in my next presentation. Okay? Benign, of course, after the mastitis lactation, and I have to say that in our department last year we had 12 cases of cancer during the pregnancy at women under 40. I don't believe that lactational mastitis has anything with breast cancer, but lactation mastitis investigation, lactation mastitis which is going on, it is recurrent, and you will not find an inflammatory problem or an infection or a rare infection, as you will see in my next presentation. And we should think of an inflammatory breast carcinoma at any age. And the recurrence and also the healing with a defect, it is a galactocell. It is the one of the ductus which gets without any exit, and then we'll get the galactocell, and it might be super infected. And the subacute mastitis without pain also should be followed up, and culture guided by biopsy should be done. There is an ABM protocol. This is Academy of Breastfeeding, and of course our aim is to heal the mastitic inflammation and to treat the bacterial, recognize and treat, and also prevent the recurrence of the ABM. Very much attention should be done in premature baby, as I've told you. In when we have women with diabetes, with special condition, women with immunocompromised group like lupus erythematosus. Also, they have other medication that might lower the immune reaction, and we know that the women in postpartum, they have a low immune reaction anyhow. So the fever, the general fever, it is important, and it is considered as a immunocompromised population. It is important not to prescribe antibiotics empirical, not to apply heat, not to want to empty breast, not to sterilize the pump, just the other devices, and take care of the woman even after you consider that the lactation mastitis, it is healed, if the erythema persists. And inflammatory part, it is important to be follow up. It is a clinical constellation of a spectrum, and it's important the follow-up in the clinic. This is a sort of workflow. It is important to continue the lactation, to do the ultrasound if there is an abscess, and of course to get the culture and to get the proper treatment according with antibiogram. But what is important is to follow up these women. Like optimal attachment is important, and it is very important the first episode to be correctly treated and follow up. So one of the things we have to take in consideration is prescribe less and listen more. So as the doctors in the first part of the COVID, the doctors in California get a protest. Let us to talk with our patients because their contact was limited. So the most important thing is to listen to the patient and listen more and to decide the best treatment for the best moment it is. All the, like even it is a very old problem of the breast, there are very, very new follow-up guidelines and also research, a lot of research in this area, because as you know, in Japan and in Germany, for the first time, we have now milk bank. They are saying not money, but milk, and sometimes for some babies with nutritional problems, it is important. So for the students and for the residents, research in breastfeeding and in milk composition, it is very important because we cannot promise our patients forever life. Everybody will die, but our attitude and treatments, we may increase the quality of life. Thank you.
Thank you, Dr. Chelsi, this perfect presentation. Do you have any comments and question about this topic? We have enough time and we will take some questions from audience. Go on.
For inviting me to speak here today. It is such a pride and I'm very happy to be here. And thank you for all the hospitality. My talk today is about granulomatous mastitis. It is actually an under-diagnosed and under-studied benign inflammatory disease of the breast, whose accurate diagnosis is confounded by mimicry of other breast pathologies. It was first described by Kessler and Walsh in 1972. Actually, in our area, this disease we face a lot in the Mediterranean area. This disease is not well known in the Western regions or even in the southeast of Asia. So it's actually a disease that we need to study because it affects our population more than other populations. The etiology is not yet really clear. There may be association with some Corynebacterium, especially, but not exclusively. Sometimes it is related also to hyperprolactinemia. Sometimes we differentiate between the mastitis that is caused by the Corynebacterium or other mastitis and differentiate between them. But the etiology is not yet, till now, not yet clear. It is a rare disease, affects 2.4 in 100,000 of women. It has predilection toward the premenopausal women with recent pregnancy and lactation history, and most prevalently affect Hispanic, Black, and Arabic and Asian women. It usually occurs in this period of age 32 to 36 years old. what is very important to know is that granulomatous mastitis has no increased risk of subsequent breast cancer patients. So when we are dealing actually with, since we do with breast surgery, yes, the patient is happy that she does not have breast cancer, but I think all of us as doctors, we are frustrated when we deal with a patient with granulomatous mastitis, because really the progress and the healing of these patients are very difficult. So yes, patient is happy, but the doctors are not happy. Clinical presentation. It usually comes with a solitary peripheral tender inflammatory mass, usually unilateral, but there are bilateral cases up to 8%. It can present as multiple simultaneous peripheral masses, rarely central, with abscesses, overlying skin inflammation and ulceration. Nipple retraction, sinus formation, podorange-like changes may accompany these findings. Even axillary lymphadenopathy, since it is a chronic inflammatory process. Idiopathic granulomatous may present with repeated abscesses over weeks to months. This finding may be confused with breast abscess or malignancy. As we can see, it has both features of inflammatory and malignant breast conditions, and sometimes with the initial presentation, the diagnosis is not very clear. If it is early, we can really differentiate it with abscess, and because the treatment will go in a different pathway, but also sometimes it is difficult to differentiate it between granulomatous mastitis and even malignancy. We can see here some presentation. In my experience, I have seen at least 5 to 6 women who ended up with mastectomy only for granulomatous mastitis. But this was really long time before. But some patients will suffer that the breast is too much deformed. It is a source of pain. They only have sinuses, and they are not happy with it. And the best actually approach is just to do a mastectomy that is very comfortable to the patients. The diagnosis of, as they are young women, so usually the first step in the diagnosis is doing ultrasound. It has a lot of features, but it is mainly a regular hypoechoic mass that is heterogeneous with ill-defined margins, and we can find some fluid collections. Mammography can be mistaken with malignancy because it's a regular mass with focal asymmetry. If in doubt, and if needed, MRI, it will show heterogeneous in T2 weight image. It will be hyper-intense lesion with rim-enhancing masses. This is like mammography. We can see that it can be a follow-up this year for before and after treatment, the resolution in MRI. Here we can see the findings in MRI for inflammatory granulomatous mastitis in the T2 weight image. Ultrasound is very important. It will show a regular hypoechoic mass with fluid around. If we are in doubt, also we can see in elastography, it can differentiate because the vascular pattern of granulomatous mastitis differ too much from malignancy. So using elastography is also very useful if we are going to see. This is how it looks in mammography. So sometimes it really means malignancy since it is irregular, even some calcification may be there. So the differentiation in mammography is really sometimes difficult. So the pathogenesis of granulomatous mastitis is not fully elucidated. Suggested mechanisms include autoimmune response to milk stasis, thus lactation and hyperprolactinemia with resultant ductal ectasia are risk factors. Reaction to trauma and infection with Corynebacterium coropenicillii have also been associated with granulomatous mastitis. I have published one article in the past, and we found a very strange relation between having rats in the house and the incidence of granulomatous mastitis. It can be related to social level, or it can be related to, I don't know, but we found this relation epidemiologically before. Differential diagnosis includes many things: all chronic inflammatory condition, all chronic granulomas, tuberculosis, breast cancer, even any autoimmune mastitis that can be caused, sarcoidosis. These are all can come from differential diagnosis. Of course, the only way to identify the correct pathology is with the pathology. This is how it looks in the pathology, and this is how to differentiate it between other entities that mimicking the granulomatous mastitis. For example, in tuberculosis, which is also a granuloma, we will find necrotizing granuloma with central necrosis. Central necrosis is not there in granulomatous mastitis. Other infection, also granuloma, or maybe also necrotizing, depending on the pathology. Sarcoidosis, it is non-necrotizing granuloma in breast stroma. Mammary duct ectasia, we find mainly periductal granuloma, sometimes dentogranulomatous features. Foreign body granuloma, we can find the foreign body itself with giant cells. But in idiopathic granulomatous mastitis, it is lobulocentric granulomas with cystic spaces, neutrophil, and possible corynebacterium. So this is the key feature of how to diagnose the granulomatous mastitis from the other pathologies that can mimic the condition. Treatment options. Although antibiotic treating corynebacterium are often prescribed for idiopathic granulomatous mastitis, I myself used to treat with rifampicin. I was giving a low dose of rifampicin, but for a long time, and I had good response with this treatment. But there is no clear evidence that this approach alters the course of the disease. Thus, corynebacteria may not be the causative factor in most patients with idiopathic granulomatous mastitis. No specific management is necessary for granulomatous mastitis, especially in patients with a small unilateral lesion without sinus formation or abscess. It is frequently a self-limiting inflammatory condition that resolves slowly. Complete resolution may take 5 to 20 months. So we just, if a patient is coming with no pain, no secondary abscess formation, just a granuloma after reaching to the final diagnosis, no treatment can be given. This just follow-up of the case, and it will show spontaneous resolution. Surgery, I don't advise. Surgical excision for granulomatous mastitis can be followed by slow wound healing and is not advocated as an initial treatment. In one series, 120 women, most cases resolve spontaneously without surgical intervention or medication. So many studies were done, demonstrated comparable recurrence rate between cases that managed with surgery and without surgery. And we are here speaking about condition that the patient does not have pain, does not have secondary infection, and she just is coming with a mess. Anyway, even surgery can be needed to secondary infection, symptom control, or marked deformity. These are the current indications. How about the patients who are come with abscess formation? So they have the granulomatous mastitis with abscess formation. This is really very common condition. Treatment is usually with repeated needle drainage and antibiotics, usually result in resolution, with also no need to do surgery. If suspected abscess detection can be confirmed by ultrasound, followed by ultrasound-guided needle drainage, which also provides samples for culture, antibiotic sensitivity testing. Antibiotic selection should be dictated by culture and susceptibility testing. Pending culture results, we generally start with something that is common or oral regimen in that is covering most of organisms. If only corynebacterium is recovered, the optimal management is usually we start with doxycycline, 100 milligram twice daily. This can be for 2, or if not, if no response, linezolid 600 milligram twice daily. So if we have abscess formation, we will give antibiotics together with ultrasound aspiration that can be also repeated till the abscess is recovered. The optimal length of therapy is actually uncertain. A 5 to 7 day course, this is the usual. But if the response rate is, if there is still no response, we can extend to 10 to 14 days. There is little evidence that antibiotics shorten the time to full resolution of granulomatous mastitis. The problem, we are here treating the secondary infection, but this will not affect the granulomatous mastitis itself. That's why we cannot really see clinical resolution that is we expected, as we are treating just other mastitis that we will find really patient is now free. But this patient will only treating the secondary infection with the abscess formation only, and he will still remain with the granulomatous mastitis. How about if the patient is coming with pain? Pain is usually managed with non-steroidal anti-inflammatory drugs. Several studies suggest that topical steroid can be also effective even in patients with skin involvement, including small ulcers of fistula. Treatment protocol vary considerably. There is consensus that medium potency topical steroids should be used. There are topical corticosteroids can be affecting, they are very effective in treatment in this condition. This approach has the advantage of limiting the adverse effect of systemic steroid. So we can start with local steroid together with anti-inflammatory drugs. How about if it is associated with hyperprolactinemia? In this case, we give antiprolactin like cardigoline or bromocriptine. These patients also will help in the resolution of their condition. Then comes the other criteria of patients who we treated, but we did not succeed and they did not resolve. So patients with refractory symptoms or persistent symptoms. The recurrence is common and associated with lesion size and number, so we'll have increasing numbers of lesion and enlarging of the size of the current lesions, also with fistula formation. The optimal management with persistent symptoms, usually they need topical or systemic or intralesional steroid. And we've just shared the paper that is done here in this university comparing the systemic steroid with intralesional steroid. And they found that superiority of intralesional steroid as you also avoid the side effects of systemic steroid, because some of these patients are diabetic. They really do very bad with administering systemic steroid to them. So local steroid was found as effective as systemic one, together with less side effects as if it is generally administered steroid. How about methotrexate? Many people are using methotrexate to treat. However, it will be for the patients who are not doing well with steroid, either steroid resistant or dependent, or steroid not responding to steroid. It can be useful to reduce pain, fever, swelling, possibly deformity. However, some other people are not using, are not advocating, but this is very currently the scheme. If steroids fail, we will resolve to methotrexate. People who are advocating this, they will start with methotrexate, then they will end up with only prednisolone alone, but they will start that main treatment first with methotrexate. The dose will be 10 to 15 milligram orally per week, so it's not a high dose. It will be administered together with steroid. In one observational study, including 19 patients, most of whom were refractory to antibiotic, steroid, and surgical intervention, use of methotrexate was associated with a disease remission in 75% of cases. So as we can see, it was really effective in some of the patients. Some studies were coming actually not from breast surgery patients, from dermatology, but they found doxycycline was very effective because many of these patients go to dermatologists as well as they have skin condition in their breast, and they were actually giving good treatment with doxycycline. Another study, 57% of another study of 49 patients with confirmed granulomatous mastitis, 57% underwent observation alone, 24% steroid, and 19% had surgical resection. The average time to resolution was longer in patients who had observation only. The authors concluded that intralesional steroid injection was an effective treatment of granulomatous mastitis. Selective management was appropriate. Surgical resection is not required for most cases. How about surgery? Surgery rule is really uncertain. Being a surgeon for the breast for over 30 years, I'm not happy at all to do surgery in granulomatous mastitis. Sometimes we need to, if we have to. Severe deformity, non-resolution of fistulas or abscess. Many of these patients will end in having a mastectomy. If mastectomy is done, I don't recommend at all to do reconstruction with the same session of mastectomy. Better to be delayed form of reconstruction. Surgery is reserved for people who have diffuse disease, recurrence, ineffective conservative treatment. Wide local excision can be done, and large masses will produce breast asymmetry. Even a mastectomy can be needed. Thank you so much.
much for your excellent presentation. Is there any question or comment for Dr. Tamer Yusuf? Yes, please, Mehmet Hocam.
Thank you for your presentation. I'm from Cerrahpaşa. We have great experience about this grammatosmarsitis. I have some comments on your presentation. Expectant management is a good option, but as even it's a benign disease, if you prefer expectant management, especially in your slides, you write it's more than 5 centimeters, the treatment prolongs. However, the quality of life decreases. So we should do something for the patient.
I said very clearly, expectant treatment for patients who have asymptomatic mass. So this patient does not have pain, does not have abscess. She has a mass that was confirmed to be granulomatous mastitis. The patient is asymptomatic. She has a mass, yes, but otherwise there is no other complications. She does not have pain, so there is no effect in these patients. Expectant treatment and just follow-up is recommended.
Anxiety is also reducing the life of quality as well. We also prefer expectant management, but for rather than smaller, to help. Another, as you see, cystic neutrophilic grammatosmarsitis is a distinct subtype of grammatosmarsitis, often associated with that bacteria you mentioned. However, to show this on cultures is difficult. Instead of it, we should we should have an experienced breast pathologist, and he or she should show us cystic tuberculosis.
Yes, I agree totally, but I think we have another presentation for rare inflammatory condition that will cover the other things. That's why I don't want to encroach on the other presentation.
Yes. We have cases that our pathologist shows that this is cystic neutrophilic grammatosmarsitis, and really these patients previously got other steroids and other treatments, but clarithromycin and tetracycline is very valuable for these kinds of disease. So first we should have an experienced pathologist to show this disease, and the other one, the surgery. Did I mention wrong? Do you advise surgery for the resistant cases? No?
No. I advise surgery for marked asymmetry, deformity, persistent masses that is not responding to all these measures from before. And my advice is to always try to delay or even escape from the surgery, because the surgery will end up, if it is just excision, will end up in more deformity without really improvement of the symptoms of the patient. You will have more fistulas, more sinuses. The scar will not heal if this is the results of the surgery is like, unless it is a persistent masses that is not responding to anything, or actually, as I told you before, at least 4 or 5 cases in my life I saw ended up in mastectomy from severe deformity. Patient coming asking for mastectomy.
Yes, we don't prefer mastectomy for disease.
It's too much. Now we are trying to escape from mastectomy when we are treating cancer, and then you will treat inflammatory condition with mastectomy. It's really too much. But when the breast is only just deformity with sinuses, then patient does not really feel she has a breast. So she will be better treated with mastectomy with delayed reconstruction.
And the last comment, in one of your slides, for methotrexate, there was no controlled studies you mentioned, but we have controlled studies, especially in Turkey. We have some published studies, especially from Cerrahpaşa. For 10 years, we use methotrexate for refractory resistant cases, or even for primary cases, especially for hypertension or obesity, and we really get good results after methotrexate.
I saw that methotrexate, I said it is getting good response, but maybe there are not too much controlled trials. The disease is only restricted in our areas. That's why there is not a lot of literature available on granulomatous mastitis. That's the issue.
Thank you.
We can take one question, please. Alıt Hocam, buyurun.
I want to learn if you have any observation about it.
Generally, we see these granulomatous mastitis in young and socioeconomically lower population. Can you say
Same observation I find also.
generally?
Yes. The commonest age, as I mentioned, 32 to 36. And I told you in my research before I did, I found association between having a rat in the house with granulomatous mastitis, and it was correlating positively with statistically. I don't know if it is related to the rat or the socio-economic standards of the patient, but we found it.
Thank you very much for your presentation. So, do you do exclusion of tuberculosis before starting any immunosuppressive therapy routinely?
Yes, in the biopsy and the cultures of any fluid, we must exclude first all the other differential diagnoses.
So the second question, so you said that this disease also, maybe I misunderstood, starting from the terminal ductal unit.
Yes, lobulocentric, yes.
So I feel like, you know, it's starting from the behind the nipple, because every case I've seen, with my very limited experience, nipple and the main ducts just behind the nipple was involved. And I think, so during the surgical resection, because I have done a few, if you left those ducts behind, so the disease comes back, I think. What do you think about it? Thank you very much.
Okay, so it's also one of the differential diagnoses, maybe it was not mentioned here, is mammary duct fistulas. If it is really mammary duct fistula, yes, I agree. If you have a fistula, that you need to resect the whole duct from the fistula's opening to the end of the duct, but not in all cases of granulomatous mastitis. But if it is complicated by mammary duct fistula, which can happen in other conditions, periductal mastitis, all this can also cause mammary duct fistula. I have treated some in my life. In the fistula, you need to do this, if there is fistula. But not every case. Some cases are isolated and peripheral. They don't have fistula or connection to the major mammary duct.
Okay, thank you, Dr. Yusuf, for your excellent speech. Now, I want to invite the next speaker, Hasan Besim, chronic periaureolar mastitis.
Mrs. Chairwoman, esteemed colleagues, guests, thank you very much for inviting me here. This is a privilege. I am going to talk about a bit nasty thing, the chronic periaureolar mastitis, which is a disease of the young individuals, young women in general. In fact, it is known for more than 1.5 centuries. And it was described by Birket, Bloodbrook, but it was Zuska and his colleagues who gave their name to the fistula, to the condition as fistulas of the lactiferous ducts, or mammary duct fistula. In an article they present in the American Journal of Surgery. The chronic periaureolar mastitis, also known as periductal mastitis or Zuska's disease, is a complex, benign, but often recurrent inflammatory condition of the breast, typically affecting the non-lactating woman and middle and young age. But it affects a wide range of ages, starting from mid-teens, ending up in 80s, and may even be observed in males. The chronic periaureolar mastitis affects the terminal lactiferous units, ducts, and it is responsible for the 1 to 2% of all symptomatic breast conditions. And it is characterized by recurrent periaureolar inflammation and infection, which can present with or without a mass, abscess, or a mammary fistula or sinus, and it is strongly related with smoking. Almost 90% of the cases are smokers, The median age is in the 30s, 32 to 34 years, and there may be nipple inversion, obesity, diabetes, hyperprolactinemia, and sometimes antidepressant usage is effective in their development. This smoking is very important, I said. It leads to squamous metaplasia and epithelial to mesenchymal transition in the ductal epithelium, and the epithelium turns to squamous epithelium. So keratinization takes place, plaque formation occurs, and this ductal obstruction leads to bacterial overgrowth in most of the conditions, which leads to an inflammation, an infection, an abscess, and then it ruptures to the periareolar area, and a sinus is formed with the duct. A fistula is formed, or a sinus is formed in that region. It is independent of breastfeeding. There is massalgia, hyperemia in the periareolar region, and there may be nipple discharge. It is not a must. There may be a nipple areola complex deformity or retraction, and subareolar breast mass with or without mastitis is present in many patients. The sinus formation or fistula formations is seen in 1/3 of the patients, and almost up to 50%, half of the patients experience recurrent somewhat in the course of the treatment. There may be purulent drainage from the breast, the fistula coming from the nipple areola complex, or just the border of the areola, outer border of the areola, or there may be dormant sinuses and fistula formations in which no drainage is seen. There is a classification of periductal or chronic periareolar mastitis, starting from the easier, non-complicated ones, which present as a mass without an abscess or fistula. This is the type 1. And when an abscess is developed, and it is small, it is type 2A, smaller than 3 centimeter, and bigger than big abscess, type 3B. A fistula formation without a breast mass, and then when everything is present, a complex refractory case is the type 4 one. The diagnosis is generally a clinical one, but we use imaging to exclude any other concomitant problems. Ultrasonography is the first line of the techniques, radiological techniques that we use, and there may be dilated subareolar ducts, or periareolar inflammatory changes, masses, abscesses, fluid collection, and the mammography is non-specific generally. There is subareolar density, and architectural alteration is present, and it is generally done to rule out malignancy in older patients. MRI is helpful in assessing the extent of the disease, identifying complex cases, the complex fistula, and excluding cancer again. And a tissue diagnosis may be required in isolated cases. The diagnosis imaging, yes, it is shown here. The first picture is a mammogram showing the density in mediolateral oblique projections. The ultrasonography is seen, a fluid collection in the suprareolar region in the second up, and an MRI shows a cystic mass in the periareolar and retroareolar region of the patient. What about the microbiology? While bacteria is generally isolated, cultivated in this problem, it is debated whether the cause is the bacteria itself, or they are secondary invaders taking advantage of the tissue injury and the obstruction. The key pathogens are predominantly the cutaneous microorganisms, the staphylococcus, but especially in smokers, anaerobic bacteria are more commonly isolated. More unusual pathogens are generally present with an immune suppression state. The differential diagnosis may include idiopathic granulomatous mastitis, inflammatory breast cancer, or breast tuberculosis, especially in endemic areas. If you are from one of those areas, you have to take that into consideration and rule out the tuberculosis in such patients. The treatment paradigm is shifting from simple drainage from more complex duct resection procedures. But I may say that if one problem has different presentations, or if one patient has different surgical interventions that are tried, no one is optimal. And of course, the smoking cessation is very important, and if this can be done, probably it will be best for the patient's satisfaction in the long run. Percutaneous aspiration, if you are going to drain an abscess, is preferred over incision and drainage alone, because incision and drainage may be lead to an fistula or sinus formation. Antibiotic treatment must target the aerobes plus anaerobes if you are going to prescribe one, so co-amoxiclav is given to these patients in general. The comprehensive treatment, the simple drainage or excision and antibiotics are not generally sufficient without an intervention towards the ducts, as my previous colleagues state. When we look at the details of the surgeries, there are minimally invasive interventions like incision alone, incision and drainage, breast duct irrigation with ductoscopy irrigation, or sometimes ultrasonic guided breast duct irrigation. And then comes the minor excision procedures to open that duct and to pack it, to leave it for secondary healing. The primary closure can be done, but there may be problems about it if it is not if it is without antibiotic use. Then additional nipple part resections, removal, are tried as well. The major excision is the hip, and it can be done with a circumareolar incision, the Hatfield procedure, or a radial extension, an urban procedure, and the complete duct removal. Not only the involved duct is removed in that patients, generally with the surrounding inflamed tissues. There may be oncoplastic approaches again. The thing that we learn from oncoplastic surgery of the breast cancer, dermoglandular flaps or periareolar oncoplastic approaches, round block resections are tried, and it is shown that they have better recurrence scores. There was a review, a systematic review and meta-analysis from the 2021. They get many patients, and they analyze the minimally invasive, minor excision, major excision, and the oncoplastic approaches. And the thing they found is generally the incision only, or the incision and drainage are worse, and the primary closure without antibiotic treatment is not good. The treatment failure rates for incision and drainage and incision alone are very high. The breast duct irrigations rate is about 20%, and the pooled TFR, yes, for breast duct irrigation is up to 19.4, 20%. So it could be chosen if the case is limited, but you have to know that in complicated cases, it is not something to be chosen. In the minor excision with wound picking, the primary closure under antibiotic treatment and additional part or nipple removal had the lowest one of the lowest failure rates. And patients with recurrence tend to have nipple abnormalities in general, blocking of a nipple and such as total or partial nipple retraction. And if you resect that part of nipple, you will have a probably lower recurrence rate. In the major excision, the Hatfield or urban procedure, the infected tissue is excised with the ductal system. The Hatfield procedure had in this paper 7.5% recurrence rate, and the urban procedure much lower. And the dermoglandular flaps and periareolar oncoplastic approaches again have very low recurrence rates. This is a paper from Turkey as well, and showing the operative intervention and their final results. Yes, there may be complications with suprareolar exploration and duct resection. Nipple numbness, paresthesia, nipple inversion or retraction can be seen, scar formation or infection, hematoma, general complications, even nipple areolar necrosis. And of course, you have to inform the young individual that there will be a loss of breastfeeding ability, especially in that breast if you totally resect the breast ducts. Even in partial resection, the later breastfeeding may be problematic. You have to inform them. And the general recurrence rate is about 11% in the pooled data. So in conclusion, the chronic periareolar mastitis is a complex disease with high recurrence rates. And incision and drainage alone or minor excision with primary closure have higher recurrence rates, especially when they are not complemented with antibiotic treatment. Breast duct irrigation, which is the most minimally invasive procedure of all treatment options, seems to yield acceptable outcomes in limited in grade 1 patients. And definitive treatment should consist of excision of the affected ducts with the surrounding infected tissue. But I may add that further research is still needed to better understand the etiology and pathogenesis of this chronic periareolar recurrent mastitis and to explore more effective treatments of the disease in the future. Thank you for your attention.
Thank you, Dr. Besim. Do you have any question or comment? Yes.
Thank you for your presentation. This identified radiologically and demonstrated radiologically. How does it work, really? Because we don't have experience with it.
I don't have any experience with it, but generally ductoscopy is the preferred method for that.
So it's done through ductoscopy, not radiologically.
But in the literature there is.
And the second question is whether stopping smoking actually can reverse the changes, the periductal changes and the ductectasia, or is it is the benefit of smoking cessation related to better healing or less inflammation or less infection?
Yes, the cigarette smoke is a toxic substance to the epithelium, in fact. And yes, one is already obstructed, one duct, but when the smoking continues, probably other ones also will have the same problem. And you get rid of the one problem and you add on other things. So in general, yes, the harm is already done and you are going to do something for that certain duct. But there are too many ducts there that yet waiting to be obstructed.
Thank you again, Dr. Hassan.
Thank you.
I would like to Dr. Chatri again for her second speech. The title is Rare Non-Lactational Infectious Condition. Dr. Chatri, please, again.
Thanks again, Dr. Bahadir, that he gave me this lecture with rare non-lactational infection condition. Actually, it was a help for me to review even for myself because they are rare. And the diagnosis of these non-lactation infectious conditions from the symptom to diagnosis, there is cited a medium of 100 days or minimum 7 months for leprosis of the breast. So these things, it is a continuously intelligent workup for the getting a correct diagnosis for inflammatory disease of the breast, and also to have a complex differential diagnosis, and it is very good for the school and very good for the lectures, and also very good in nowadays when we are facing a shifting in the way of thinking, and also we have a lot of laboratory devices we should use in our diagnosis. So if Dr. Dinas is not loving his imagist, I like to talk with my imagists, but also with the lab technicians and lab doctors we are having in our hospitals. Because without them, we cannot ask for, we have a sample. We have a sample from a breast that we want to get the pathogen, but where to send and what they will do with it. It is exactly like with amniocentesis. You get the fetal cells, but what to ask? So in this complex diagnosis of non-lactational mastitis, it is a way, and I'm trying to do this with my residents, and this is a class for Benign disease. It is constructing the architecture of a diagnostic. And when I constructed the architecture of the non-inflammatory lactation mastitis, I find 8 of the rare disease in the first place. So there were more 12, but I cut them because they were rare, but you can find in the list. And then I think that we have to think of 3 principles in how we get in front of a non-lactation inflammatory disease of the breast. First, any infection is polymicrobial. And we have pathogens, that there are pathogens in the people with normal immune reaction, but as we learn, there are people with low immune reactions, and in these people like diabetic people, like HIV people, like people who are under the treatment, and all of us, we know that the inflammatory diseases like lupus erythematosus and other inflammatory disease, that they are under methotrexate, they may have low immune response. So in all of this, we may find pathogens that they are commensals, and they may cause infection and inflammation. The other problem is which is the top rare infection. It is tuberculosis. And nowadays, we know that tuberculosis becomes a warning all over the world because of the migration and because of the highly resistance of the tuberculosis pathogen itself. And it will, if in the cancer we may say that it is lowering the age of the cancer, but in tuberculosis the young people are dying. And I can tell you that in Bucharest we have one very good cardiologist, 42 years old, who died of tuberculosis 2 years ago. And it was a highly resistant tuberculosis. He went to be treated in Switzerland. There is an institute, and all of us should know that there is a WHO community where they answer if you call at any time, at any hour of the day, and if you present a case or you send them by email, they will help you to find a solution or a treatment in a very rare disease, in an infection with rare pathogens. And the third pillar in this framework, it is that if you have a resistant and a persistent inflammatory condition of the breast, you don't have to think which antibiotic should be added. It is which pathogen should I look for in this context. What is rare? And rare, it is rare that you see here that tuberculosis in the United States, in the breast disease is under 0.1%, but in the endemic regions, not in the United States, in Americas, both North and South, in the United States it is higher. We have to think in two ways. One of the ways is they are putting the diagnosis. They are having a workflow and they have the capacity of putting the diagnosis. In Canada it is the same capacity, but in Argentina it's not. So we may not look at this map only from the point of incidence and what is rare, because in United States it is rare, but it has a high prevalence of tuberculosis in 2026. And we learn from pandemia that the people will not die from cancer, the humanity will not disappear by cancer, it will disappear by an infectious disease. And tuberculosis is one endemic that it was found also in the mummies from more than 3,000 years ago, and they still found the Bacillus tuberculosis capable of doing pathogenesis in alive tissues. Again, what we will start as an approach, here I could not put 3, I would have liked, but I found 4 pillars. So first of all, it's to talk with the patient, to investigate, and she will remember that she was in North Africa, or she was in south of Thailand, or she was in Malaysia, where the rat in the house, it is important because the rat will eat the snake who is coming. So they are keeping the rats in the house for their protection. So in places where there are different social and domestic habits. Also, the tuberculosis is very high also in the women that they are having, and in India they discovered this travel surgery. It is too expensive to get this surgery in Turkey, as I will go to Afghanistan or in India, because there it's very cheap. And they are doing the piercing, they are doing the cosmetic surgery. Also, there are places where they are doing the cosmetic surgeries in other places just because they are not allowed in some countries. Habits, piercing, yes, we know that the piercing and all the stuff that they are metallic implants at the level of the breast and in genital parts, they might be associated with local persistent infections. Imaging, ultrasound. In these diseases, it is the only place where we will not put the mammography. The mammography does not help us, and in granulomatose, as Tamer presented so nice, it is not helpful. In 30% of the cases, the mammogram will not show us a relevant image. We can use ultrasound as the first line, and it also is very cheap. And in complicated cases, MRI and PET, and we know that even from the breast cancer and approach, that there will be lesions that we will see only in MRI, only in mammography, and only in ultrasound. The tissue sampling, we need to take tissue sampling, we need to give not only to the pathologist, we need to give them to the lab also, and here not final needle or final needle aspiration. In these cases we need core needle biopsy, enough tissue to be sent also to special, very rare coloration, and you know, Till Nielsen for the tuberculosis is one of them, and it's specific. And what analysis we will do? Because they are very rare. In tuberculosis, as you will see, you don't expect to find any positive coloration. In 30, more than 30, and in some cases, they are pouchy bacillar lesions. And there are specific molecular 16 genes, and they will get from 16 to 32 genes to 9 genes. They will get the definition, the genetical marker for that bacteria. And this is now the way to make the diagnosis of tuberculosis, of Corynebacterium, of actinomycetes that we all discussed in the last 15 minutes here, and also mass spectrophotometry type of analysis. And if you send just this to the lab for an infection, it is not enough for an accurate diagnosis. Actually, tuberculosis as an entity in the breast, it was discovered and it was described 50 years before the Bacillus Koch. It was discovered by Koch. It was Sir Ashley Cooper in 1829. He described the first tuberculosis mastitis. So they were no tuberculosis, it was a lesion. It was one tumor, mostly in the upper quadrant, because there it was probably a hematogenous spread, and there in the upper quadrant, superior upper quadrant, there are 90% of the lesion of the breast. And also the spread can be also contagious directly from the tuberculosis mass from the pulmon, but also lymphatic. So there are described all types of route of infection. And it is important to think it is the first. It can look like this, and I remember 20 years ago when Tamer showed us the first granulose mastitis when we arrived in Alexandria in Egypt in a Manos Med meeting 20 years ago. The granny of mom is Manos Med. And I saw first such a lesion. I've never saw this in Romania, but last year I saw 3. And one, it was in a Romanian lady, and 2 were in 2 ladies coming from Afghanistan as a migration. So it is important to think, it is important to know this pathology, it is important to know where to look, which is the best for the moment treatment, because once you put the treatment, you need this 4 combination as a first initiation, and in Romania it is a supervised treatment, so the women are going to a specific center and they are going the treatment from the hand of a nurse to be sure that they will get the treatment. It is they have a lot of adverse effects, and some of them they avoid to take if you prescribe them at home. And then another 4 months with isoniazid and rifampicin, and the surgery, as it is very nice, said Tamer, if it is needed, if it is symptomatic, if it is advancing at stage. And the most important thing to remember in mastitis, if you have a negative culture, you do not in Thiel-Nielsen coloration, you cannot exclude tuberculosis because it is pouchy bacillar the lesion. Non-tuberculosis, which is mycobacteria, there are also many mycobacteria, and here again there are ladies that they are coming after surgeries. Most of them, they are coming with infection and also with implants and mastectomies after augmentation or breast reductions, with tattoos and piercing and mesotherapy injections. So their most, and it is described as an antibiotic nightmare. They have antibiotics for 6 or 9 months after an implant, and actually it is a mycobacteria supra-infection. And there are several specific description of the vacuoles. It is a neutrophilic cup that they are making also the fibrosis around the implant, and also macrophage, and sometimes you have to remove the implant and then to find to treat the granulomatous mastitis. And the diagnosis, they are called sometimes idiopathic granulomastosis, because in 70% of the cases you will not find the infection. In 30% of the cases you may find Corynebacterium, as Tamer already said, and I will not repeat everything. So it is important to follow up and to observe the lesions and the inflammatory process. The treatment, actually it is approved, and rifampicin, it is the last. You may give the treatment as doxycycline, then it is trimethoprim with sulfatiazole, as we described, in double doses, and the last one in combination if it is a biofilm. I hope that everybody knows now the concept of biofilm. Biofilm, it is like a culture which is self-supported, and in this culture it's very difficult to get the antibiotic concentration. So if it is a biofilm, it is like you are having a cover in which the concentration of the antibiotics, it is very low, and in these cases of biofilm you need also the treatment to be added at a longer time, and also sometimes the drainage, it is very important. Actinomycosis, it is something that is confounding. Actinomyces, it is something for the students. If you want to confuse them, they will say 90% that it is a fungus. Actually, it is not a fungus, it is a bacteria, and it was misdiagnosed by because they have some layers, and they are bacteria, and you need to give antibiotics. There are many, and you don't have to treat with metronidazole. Actually, the people are adding at the third therapy metronidazole, which is not only it is not only important not to give, but it will also cause damage to the tissue. It is the fungal mastitis, and I will stop just to say that Histoplasma capsulatus, it takes 100 days to be diagnosed in a case of a woman who had breast augmentation and she lost both breasts. It is a clinical case in the American Journal. You can read her story, it is very important. It's a story from 2023. Candida is controversial, and to stop the controversy, Candida, it is not in the breast. Candida is just on the breast. The entity of intraductal candidosis does not exist, it is not recognized in 2026. It is just on the skin, and it should be treated like a lesion on the skin. Brucella and breast filaria, they are also other rare pathologies. Here you also can look on the internet. It is something that is dancing in the breast for the people who are coming from that area. Hydatid disease, unfortunately, it is in 2026 more and more. They are coming from the ships, and there it is first described as a case with first diagnosis on the breast in a woman who was taking care of the ship. In this case, it is something that if you say that this is a hydatid, exactly as it is in the liver, you should not make the punction because you may start a huge allergic reaction and the woman may die. So this is important for this specific disease. Otherwise, if you have this suspicion, otherwise the biopsy, it is important for all these inflammatory non-lactation diseases, infectious, non-infectious, and as we described, this is an algorithm for diagnosis. You can easily follow up. It is something that we already discussed, what to think, 3 causes and 4 pillars of way of thinking. Not add more antibiotics. Trust the specific coloration, but they do not exclude tuberculosis. Metronidazole, it is not a third line in non-lactation inflammatory diseases, and perform excision, limited excision, because the surgery is not curative and may give very bad results. So when the breast won't heal, think of other pathology, other pathological germ, not to add more antibiotics. And also I invite you to the Academy, European Academy of Menopause and Andropause, because breast in benign condition, it is important to know the reaction, and as I saw in the first presentation of the young investigators, they should put not only the age but also the hormonal status of the woman, because we have to know how to give, not to be afraid to give contraceptive and menopausal hormonal therapy. Thank you.
Thank you again for her speech. We haven't enough time for questions.
The last topic is necrotizing diseases. I'd like to invite Dr. Mehmet Veli Dedeoğlu. We finished our time, so we are accepting you as as okay, thank you.
Good afternoon, dear guests and my colleagues. Today, I'll talk about a rare life-threatening surgical emergency, and I would like to thank the organizing committee for my topics that I have never seen before in any conference or symposium. This is the necrotizing disease of the breast, a spectrum of surgical and non-surgical emergencies. I will tell you why I use this synonym. This is close. Here we have 8 hot topics if we make a classification of necrotizing breast disease. Now I'll tell you one by one. Let's start with a case. A 39-year-old lady with fever and swelling had come to the emergency service. There was no previous history of any risk factor for necrotizing disease. She noted a redness on the superior pole of her right breast after 12 hours. This area occupied the whole breast surface, and on physical examination, there was swelling, erythema, edema, ecchymosis, and bluish blue on the lower quadrant. Ultrasound showed subdermal gas bubbles. Ceftriaxone admitted, and several hours later, a new area of necrosis. And CT shows subcutaneous gas in the deep tissue. And emergency surgery was held. Necrosis and prurulent infiltrate was noted, and selective debridement, and apparently all breast necrotic tissues was removed. And also the patient was followed in intensive care unit and intubated. Second and third debridement was later occurred. You see this picture for the second, after post-operative photo of second debridement. And after 18 days post-vac therapy, you see the picture. And the third one is 45 days after the last debridement. And finally, you see the full thickness skin graft. and cosmetic results after 4 months, all were the entire course of the disease, actually. Infectious necrotizing fasciitis is a rare but potentially fatal complication by diffuse necrosis of subcutaneous fat that spreads along the facial planes. Patients often present in septic shock or multi-organ failure, and it can be confused with abscess and cervix. It's a very rare. Unfortunately, the mortality remains high to up to 73%, especially if the treatment is delayed. The most common risk factor is diabetes. Over 60% of the cases are diabetes mellitus, and spontaneous occurrence can also occur. You see these factors, chronic renal failure, cirrhosis, HIV, obesity, and especially lumpectomy and reduction mammoplasty, and breastfeeding, especially after the infant bite, can cause this disease. And it's commonly triggered by penetrating injuries, trauma, burns, or surgery. It can be idiopathic. First report you see in 1924, or in other cases. Even following true cut biopsy and following needle aspiration can cause this disease. This is a case of gangrene breast after application of belladonna past in lactating female, and also tooth bite by infant. And diabetic female is the most common reason. And even due to poor immune status, this patient is HIV positive. Nipple piercing shouldn't be underestimated. This is a case of necrotizing disease due to nipple piercing in an augmented silicone breast. Trauma is another reason I told you previously. It's an interesting case due to a horn of a barrack in Spain. After 3 days of the injury, which was irrigated and stood in a hospital emergency room, the final result was this gangrene of the breast. You see the clinical presentations, 3 cardinal symptoms. The severe pain is the early sign, and skin changes such as edema, erythema, purple blue, necrosis and crepitus, and also tachycardia, tachypnea, hypertension, systemic toxicity. This patient died because of DIC and septic shock on the 3rd day of the stay. Thicker subcutaneous tissue and deep breach between the breasts can allow spread the other healthy breast. We have 2 varieties. Type 1 is polymicrobial, can be seen on HIV patients. Type 2 is commonly caused by Streptococcus pyogenes or Staphylococcus. These exotoxins cause rapid tissue necrosis and vessel thrombosis. And this vessel thrombosis causes skin grayish tone. We have Linex score. It aids diagnosis but should never delay surgical exploration. It's the abbreviation of laboratory risk indicator for necrotizing fasciitis. We have 6 varieties here: leukocytosis, anemia, CRP elevation, creatinine and glucose elevation, and hyponatremia. If the score is over than high, then you are close to death. The sonography reveals fascial irregularities and thickening. CT shows gas. This is very important, the finger test during the surgery. No bleeding, dishwater pass, easy fascial dissection confirms the diagnosis intraoperatively. So for the management, fluid restoration and if necessary vasopressin should be used. These patients are followed in intensive care units. Emergency wide debridement of all non-viable tissue is mandatory. Repeat debridement can be done 3, 4 more. Add vancomycin, IVIC, hyperbaric oxygen, and negative VAC therapy accelerates wound healing. This is a case following an insect bite and required a life-saving mastectomy. Another case required toilet mastectomy. For 27 years since my residency, I have seen only 1 case today, and it was coumadin-induced grammatose mastitis. However, since I have gone to this hospital, this is a Niger Turkish hospital, I go for 8 years, twice a year. I see plenty of necrotizing diseases, and after this slides, I will show you the real pictures that was taken from this hospital. Not this. Yes,
20 years old, a lady automastectomy due to infectious necrotizing fasciitis. I even didn't do any skin incision. It was already automastectomy. Another case, infectious necrotizing fasciitis. This lady's husband didn't allow toilet mastectomy and left the hospital with her. Another case, infectious necrotizing fasciitis. The positive finger test is important during the surgery, I told you previously. So for the algorithm, after suspicion of necrotizing disease, the diagnosis is based on clinical, biological, and imaging findings, and urgent emergency intervention should be required, and quickly start resuscitation, broad antibiotics, radical debridement, repeat debridement, mastectomy if necessary, and follow-up in intensive care units, and finally recovery after some time. Skin grafts can be done for breast reconstruction. You see a systematic review. The first comorbidity is hypertension and second following diabetes, and the initial source operation is total mastectomy, and the common reconstruction method you see split thickness ingraft. The second one is fat necrosis. Don't worry, she's okay. This is a benign, non-infectious necrotizing condition. Results from disruption of blood supply to adiposis that will cause saponification, inflammation, and fibrosis. You see the etiology, especially biopsy, lumpectomy, reduction mammoplasty can cause this disease. A large breast size, high body mass index, and extensive surgical manipulation can cause fat necrosis. After trauma to the breast, hemorrhage occurs within a surgical cavity and extravasate into the parenchyma, and blood dissects around the fibrous planes and will cause edema that will cause pressure necrosis, and with subsequent disruption of fragmentation of fat cells that cause at the end fat necrosis. It presents a painless, palpable mass. And skin changes you see as follow. On mammography, you can see spiculated mass, even pleomorphic, resembling ductal carcinoma in situ. So biopsy is required to exclude the malignity. And sonography, anechoic cystic spaces with posterior acoustic enhancement, and imaging fat-containing lesions with rim enhancement. Fat necrosis must be distinguished from cancer recurrence. If there is no symptom, so no treatment is required. But for surgical excision is reserved for persistent pain, cosmetic deformity, or diagnostic uncertainty. Lipofilling may cause a new fat necrosis. This is a case extensive necrotizing fasciitis after fat grafting for bilateral breast augmentation. You see the scars on both arms and breasts. Another case, skin and fat necrosis of the breast following methylene blue dye injection for sentinel node biopsy. We avoid using this. And also, it has an intense blue discoloration of the silicone implant. The third one is radiation necrosis. You didn't see the picture? A late complication of breast radiotherapy, typically occurring 6 months to years after treatment. It's caused by obliterative endarteritis leading to ischemic necrosis of the tissue. Risk factors are high radiation dose and fraction size and extent of the disease. You see chronic non-healing ulcers, pain, telangiectasis disease, and indurations are the common findings of this radiation necrosis. On mammography, you can see dystrophy classifications different from fat necrosis, and histology shows hyaline incidences, fibrosis, and fat necrosis. This is a case 10 years after radiotherapy. The calcification started to ulcerate through the skin, and mastectomy was required in this patient. Wound care, topical agents, hyperbaric oxygen, pentoxifil, and vitamin A are the conservative measures. However, this case of cutaneous necrosis after radiotherapy and with vitamin A acetate and lipoic shell base, you see the final results. However, aerotherapy doesn't work. If the conservative approach fails, then surgical debridement and flap reconstruction for large ulcers or severe pain is required. Even mastectomy for extensive necrosis unresponsive to the conservative treatments. Another case of leucistic flaps. The fourth one is ischemic necrosis from vasopressors or thrombosis. It can be seen secondary to the subclavian line extravasation of vasopressors especially in cardiovascular surgery, intensive care units, we can see these patients. This may take several days because the zone of the injury travels from deep to the surface. ICG angiography is helpful for diagnosis, but unfortunately, generally, salvation mastectomy is required. This is a lucky patient. You see the secondary to subclavian acceleration of norepinephrine. In the second picture, salvage mastectomy, and third, augmented step reconstruction was held. This is another chest wall necrosis and death, unfortunately, second to the hydrochloric acid infusion for metabolic alkalosis. You see the extent of the disease, even to the skin of the right breast, it invades. The fifth one is inflammatory necrotizing granulomatosis mastitis. It was previously told, so I didn't give in details. We can see also necrosis in clinical features. These are the skin necrosis in our clinics, and necrosis ray but can occur in severe untreated cases, and the debridement is required. There's another case, you see. The sixth one is drug-induced skin necrosis, breast necrosis. It's also a rare and life-threatening condition, typically occurring within 3 to 10 days after starting warfarin. The reason is causing by transient hypercoagulability due to depletion of protein S, protein C. And clinic presentation, painful, well-demarcated erythematous plaques that progress to hemorrhage, blue, black discoloration, and full-thickness necrosis. So what should we do? We should immediately discontinue of warfarin and pass another anticoagulant and administer vitamin K, fresh frozen plasma, wound care, hydrosteroids, and prevention. This is another case showing necrotic tissue involving the nipple and central area, and that's the second one, post-debridement VAC therapy, and the final results by skin grafts. Another case, breast necrosis induced by coumadin. The seventh one is calciphylaxis. It's a calcification of arteries causing thrombosis and ischemia. It may present as a breast mass or necrotic ulcers. Calciphylaxis causes painful skin necrosis with high mortality. These are the calciphylaxis of cases for uremic bilateral breast calcification. You see the on mammogram, on mammogram you see the vascular calcifications. Another breast fat necrosis secondary to warfarin-induced calciphylaxis, white local excision, and you see the histology there, and also on mammogram you see vascular calcifications on the left. And the final one is necrotic breast tissue disease. The breast cancer itself doesn't typically cause necrotizing disease as a primary process. However, necrosis can occur in breast cancer through several mechanisms and confused with necrotizing disease. What are these mechanisms? Tumor necrosis, or infected tumor necrosis, or necrosis following doxorubicin, or inflammatory breast cancer, it can mimic it. You see necrotic breast tumor and abscess due to tumor necrosis. This is another case of tumor necrosis. Another case of tumor necrosis. Another infected case and managed with total mastectomy and reconstruction, flap reconstruction. Another case, tumor necrosis there. This is a huge necrotic breast tumor. You see, you should manage to do the mastectomy and use skin flaps to close it. And differential diagnosis of all types are cellulitis like this, and inflammatory breast cancers, abscess and Mondor's disease. So summary, necrotizing disease of the breast include infectious, vascular, inflammatory and drug-induced entities. Early recognition is important. Necrotizing fasciitis and anticoagulant necrosis are surgical emergencies requiring immediate debridement. Fat necrosis and radiation necrosis are often managed conservatively but may need surgery. Thank you for your patience.
Thank you very much for your excellent presentation. Unfortunately, we have no time, so I have to close this section. Thank you very much for joining us. Sounds good.
to welcome you all for the last but not the least session of the day. It's my great honor and pleasure to be here. We will co-moderate this session with my colleagues, Professor Yusuf and Professor Güler together. Also, I would like to express my sincere thanks to our rector, Professor Can Türk, for this extraordinary event, and also to Professor Güloğlu for organizing all of these events and making us interact with our international colleagues as well. So we have just a little bit out of time, and I would like to invite the first lecturer, Professor Javit Karibov, for his lecture entitled Developmental Disorders and Malformations of the Breast. The podium is yours.
Thank you very much. Excuse me. Dear teachers, dear colleagues, good afternoon. First of all, I want to thank organizers of this conference and that gave me to present here today. And it's really very honorable to be here among you. And today, I think so, you are so tired. I will try to quickly explain my topic. And today, I will talk about the developmental disorders and malformations of the breast. And excuse me, I forgot to say that my name is Javit. I'm from Azerbaijan, from Baku. I'm working at the National Oncological Center as a breast surgeon. And I want to talk the breast developmental disorders. First of all, this topic focuses on the embryological problems and development disorders which occurs during the embryogenesis, and the clinics of these problems and current diagnosis and management of these disorders. These malformations and generally and disorders development problems begins at the embryogenesis, and embryogenesis of the breast is beginning at the embryonic process at the nearly 4th and 6th week of the embryogenesis, and it's beginning with forming of the milk line or mammary ridge, also called. It begins from the axillary regions and continues to the inguinal parts of the body. And the end of the embryogenesis, this milk line goes down the regression in every part, but only on the chest wall, it persists the pair of the nipples, and after that, during the maturation, during the pubertal time, the also influence of the hormonal hormones, it begins the forming of the breast, normal breast. Before talking about the disorders and malformations, we first of all have to separate them classification. We have to begin from the classification because they depends on the number of problems and depends on the size of the breast and disorders, shape and positions, and also nipple and areolar complex of the breast. First of all, we are beginning from the disorder of numbers of the breast. For example, polytelia, also called accessory nipples. For example, there is on the picture you see that additional nipples, supernumerary nipples is also called. And polymastia, what does that mean? Accessory breasts. It's also additional breasts at the axillary part of the body. Amastia and amastia, also its absence of the nipple areolar complex, and at the same time the absence of the normal breast tissue. And other problematilia, you can see that really there is little normal, there is no normal breast tissue, also little part of the breast tissue, but also absence of the nipple areolar complex we see. And amasia, this is the, there we see the nipple areolar complex, unilateral and bilateral also, but there's no normal breast tissues. Disorders of the sizes, macromastia or gigantomastia we see, and micromastia, there's no normal breast tissue, and breast asymmetry. One of the breast tissue is bigger than other is smaller than. And tuberous breast deformity, and this is also constricted breast spaces. The upper part is constricted the breast. We see an areolar herniation, the nipple areolar complex. This part we see the herniation, lower pole hypoplasia, and also elevation of the MFA, inframammary fold. And also Poland syndrome. This is the hypoplasia or absence of the pectoralis major muscles, and generally it occurs on the absence of the one muscles, so breast associated with the breast deformities, and also include ribs and upper limbs abnormalities. And generally in these abnormalities, it's not very dangerous for the patient, but if the more than one muscles suffering, more than one muscles, for example, not only pectoralis major, or may suffer also intercostal muscles, and this in the future it can cause the serious problems for the breathing of the patient. And this management of this problem, we are trying to solve with the reconstructive surgery and with the help of the LD flaps. Nipple areolar complex anomalies, invert nipples, supernumerary nipples, I said about this. Split nipples, this is not congenital problem, and generally it occurs during the breastfeeding, after the breastfeeding, and then congenital, unilateral congenital nipple absence, and ectopic breast localization. For example, you see in the back part of the patient one mammary gland, and also he has nipple areolar complex, and here in the axillary part region you see the three nipple areolar complex. You may say that it's also accessory nipple. Yeah, we can say that it's a nipple accessory mammary gland, but this is why it's ectopic, because they are not on the localization of the mammary ridge or milk line. Because of that, they are called this, we call them ectopic breast localization. Diagnosis and evaluation, firstly clinical examination and then the instrumental examination, ultrasonography, mammography, MRI, if it depends on when we need to use them. And management of the treatment, observation and research, What does that mean? First of all, we have to do observe to understand the patient, what they want from you, what they want for your operation, reconstructive operation, and what does she want to see, how will her breast will be seen after your operation. And because of that, it's very important for the patient and for us also. Reconstructive surgery, in general, we use with implants. It depends on the problems, it depends on the disorders and malformations. Reduction mammoplasty, implants, and fat grafting, and at the end of this operation, also we have to do the psychological support. These operations, these are photos of the operations which we have performed in our center, oncological center. This is the AMAS reduction mammoplasty. There was a tubular mammary gland. We have performed here the reduction mammoplasty, also a reduction of the skin. But at the left part of the breast, the upper part is, there was a breast tissue insufficiency. Because of that, we also, after the skin reduction, we also used the LV flaps at the left part. And then this is a giantomastia. This is, she had 32 years old, and she has a giant mammary gland, and this is the after operation, because also another patient, also she had a giant mastia. And it's all. Thank you very much for your attention. Thank you. Thank you.
Maybe we can take the questions just now. Is there any question for Professor Karibal from the audience?
Thank you very much.
Okay, thank you very much.
Thank you.
Next presentation will be by Professor Zervoudis from Greece. Dr. Zervoudis will talk about breast pain, etiology, mechanism, and management. A very important topic. We meet cases every day. Sometimes we suffer to find the solution.
Thank you, Mr. Chairman. Dear colleagues, ladies and gentlemen, I will speak about the breast pain, etiology, and management. As said before, mastodynia is the name. Mastodynia or mastalgia came from Greek. Mastos means breast, and dynia is the pain. It's a pain and swelling of the breast due to vascular enlargement, edema, and slightly secretory engorgement of the ducts. Actually, when we see in breast clinics the lesions, we see that the first cause of diagnosis is exactly something which is not organic, which is abnormal physiology, no disease, pain of the breast. And after we see the gross cystic disease and other conditions, ductectasia, adenoma, lipoma necrosa, and of course cancer. So it's very important in the practice of a breast specialist. It's about 70% of patients will occur in their life. They will have one mastodynia, and sometimes this could be a mild breast pain, or in about 10 to 30% we can have a major problem, very severe. Actually, we should divide these mastodynia in two categories. First, the cyclic mastodynia, which represent about 2 of the 3 cases, 70%, and the non-cyclic mastodynia, which is only about 30%, which is associated with pain who comes from another part of the breast, which is a reported pain. Actually, the two entities are different, and there are some clinical differences. Can you see? In general, the cyclic mastodynia is more bilateral in the upper quadrant of the breast, and premenstrual which is different from the non-cyclic mastalgia, which is in the lower inner quadrant and sometimes unilateral, and there is no reason. And of course, after the menopause, in general, the cyclic mastodynia regressed. About the cyclic mastodynia, the clinical features show that typically it is bilateral, diffuse, and in the out external quadrant, with some symptoms which are associated with this. In general, all the symptoms of the premenstrual syndrome. This problem of sleeping, of work, school, physical activity, sexual activity, and congestion of the breast. What is the cause of this mastodynia? It is organic or it is psychologic, psychosomatic, or it's both. That is the problem. Actually, there are many factors that can play a role to explain this mastodynia. First is hormonal disorder, hormonal association, relation with the menstrual cycle. Also, there is influence by the hormone therapy. It responds to anti-hormonal agents, and intensity of mastodynia correlates with intensity of the PMS. And we know that the axis hypothalamic pituitary adrenal, the HPA, we control the reproduction and the appetite, and also the stress response by the neurotransmitters, increase with abnormality the mastodynia. And this system is related, as you know probably, by the GABA pathway and the serotonin. And we know that when these neurotransmitters are inhibit the transmission of the pulse of one nerve of these, we have a stress response with depression, anxiety, PMS, and mastodynia. And the very important role of the hormones in this place is the progesterone, which is secreted in the second phase of the cycle, and the progesterone is converted to allopregnolone, which in the mammary gland we have very shown to induce the GABA effect of the breast, and these promote also sleep. That's why the most important problem of the PMS and the mastodynia is about 10 to 12 days before the period. So, role of progesterone, and more, I could say, the balance between estrogen and progesterone, with an increase of the estrogens and a decrease of progesterone, but also the prolactin could play a role with the TRH stimulation, and of course also the GLA, the gamma-linolenic acid, which is very important and is used also in the treatment of mastodynia. We'll see this. Also, other causes metabolic are implied about the magnesium that could be implicated in mastodynia with the irritability of the muscles, the role of the TSH by the way of the thyroid. And the second way is the retention, the water retention, fluid electrolyte balance with association of nutritional defect, and there is some association and also with some drugs or some products that are here in the front of you, in the coffee, in the tea, in the chocolate, which is the methylxanthine. This increased mastodynia. Vitamin E and selenium are not so important, maybe a little bit the vitamin E when it is associated with vitamin B6, and also the weight, for a person that have an increase of the weight, decrease the clearance of the estrogens, and by this way increase the SABG, and the 6-HBG will increase the estradiol, as you know, and in this case, of course, the adenosine will block the GABA level. Many studies refer that it's very complicated, many hormones play a role in mastodynia. And it is associated with the PMS, the premenstrual syndrome, with water retention, with many change of the psychology, and many patients have all the symptoms which are these. But also there is an organic substract of these, which is the association with histological defect, and we know that if the fibrocystic disease, the macrocyst, could be implicated in the cyclic mastodynia. But we don't have also to avoid the possibility that have also a cause from psychology, and we know that the high level of anxiety, depression, and dysfunction can create mastodynia. That's why we say, as breast specialists, we know, every one of us, that the breast and the pain in the breast is the mirror of the soul. And one patient which is very anxious could have only pain from this. So the first what you have to do is reassurance, to explain that it's not serious, and this could be effective in about 60–70% of the cases. And for the other premenstrual syndrome symptoms, which are about 10% associated with very, very severe syndrome, it is the PMDD, the premenstrual dysphoric disorder. The patient is really important 10 days before the period. We should think about the treatment, and this will act with the hormones, with the axis of the hypothalamic hypophyse ovaries, and we have many, many possibilities that we'll show you. Now, the other point is the mastodiny, which is not cyclic. In this case, it is a pain which is constant. It's not dependent of the cycle. It's not associated with other PMS symptoms. It is in general unilateral, localized in one quadrant, and is older women. Many causes are these: the mastitis, some hormonal replacement treatment, some pendulous breast hidradenitis, and don't forget that 2 to 7% of breast cancer have pain. It's something that very not well known. It's not always, of course, painful. In general, it's not, but it could be. And another point which is related to the non-cyclical mastodynia is some medicines. Of course, the hormones play a role very important with the estrogen, progesterone, clomiphene, but also the antidepressants, also the antipsychotics drugs, and other antihypertensive and, against the gastric ulcus, and also the ketoconazole, which is antimycotic, and other, some cyclosporine or corticoids that make breast pain. But breast pain, which is not cyclically, could be also a pain from another part of the body and make a pain in the breast. That is the extra mammary pain, which is confused with mastodynia, and the most frequent is the costochondritis, or the pain which came from the cervical part and make irradiation in the breast. But this could be also a fibromyalgia, so it could be herpes zoster, can be some problem from heart or for the lungs, any other situation that could make a pain which is not from the breast, but is expressed in the breast. So, the management, as you can see, is very complicated and depends on the cause. First of all, palpation. Of course, all the time we make a palpation. We see if there is a symmetry, if the pain is or not increased with the movement, if it is associated with nipple discharge or with side pain, and we know all the 12 symptoms of breast cancer with the major clinical findings that could be a nipple discharge, alteration or the nipple, or one wrinkle, or one shrink, or the edema with pot orange, as you can see in this picture. And sometimes it's something very crazy like this, for a piercing to make a pain of the nipple and the breast. So, mammography or ultrasound? Before 40 and before 30 we should of course perform ultrasound, and as we can do with 3D ultrasound. After 40, always mammography, it is the rule. But the ultrasound is the first exam in very young patients for mastodynia. And with very good device, we can see many things, cysts or lumps. And I remind that in Japan, the rule is for screening also, it is mammography and ultrasound, which is not the rule in other countries, in Singapore also. So you see many pictures that we see some cysts in this place that could be, or here, a fibroadenoma, a large fibroadenoma, which is related to the mastodynia. With angio power 3D, also we see well, but the mammography is typically necessary. We know that this, of course, is important to detect very early breast cancer. We have the ACR classification, and remind you that the ACR D, the fourth category, is very important to be checked more with other exams because it's not very effective. and the biorats classification that we have 1, 2, 3, 4, 5, and after number 2, number 3, we have to have one decision to repeat, and in 4 and 5 to perform a biopsy. Of course, we prefer mammography with digital mammography, and also with the ultrasound we can perform FNA or better core biopsy. Also, we can increase the quality of the echography with sonoelastography, with the sonograms, and with this Matsumura classification, we can have a good relation with the lesion, as you can see. The MRI is at least when you have very dense breast, when in mastodynia is in older women, and we don't have a good approach with mammography and ultrasound, and we use it, of course, as static and as dynamic study to assess what happens. And you see here, this is a large indication now in mastodynia in patients who have high risk for breast cancer, with a very high sensitivity and a less specificity. FNA will be the next step if we have one lump associated to the mastodynia. With cytology, normally we prefer to perform liquid cytology, and we use the Yokohama cytology classification, as many of you. And core biopsy is the last event when we have one reason to perform that something is wrong. But the first is, after these exams, when we don't find anything wrong, to reassurance. And after, we have the treatment. So for the treatment, it's very complicated. It depends on the cause. First, very easy, you have to tell them to change the bra and to have a sport brasserie. It's very important, without iron, very important. Secondly, to restrict the methylxanthine, which is in coffee, tea, chocolate, and goodies. To increase the vitamin B6 and E, and to avoid in premenstrual breast pain, it's better to use these foods. And very good for the breast pain are the carrots, avocado, and banana. These are very important. After this, we have the anti-inflammatories, which could be given by orally or locally, diclofenac and piroxicam. And very important is the Vitex. The Vitex, which is the Agnus castus, which is a very important treatment of mastodynia for premenstrual syndrome. And this, it is opioid with prolactin suppression effect and progesterone-like action. And this, the Gatilier Agnus castus, is very effective when we use it with the GLA, with the evening primrose oil, which is also a very important treatment for the breast pain before the period. Also, we can use hormones. Progesterone is the best in these cases. Locally, we have progesterone gel or sometimes progesterone tablet from 15 or 12 to 25 days of the cycle. And we prefer to use anti-estrogen progestative, which are the serioplinestrenol or promegestone or dydrogesterone. The pill, the contrast pill, is also one solution when it is well balanced, because we have every day the same dose of hormones. And at the end of the day, we should think, is mastodynia, it is organic or it is psychosomatic. It is a true problem. It's not so easy. And you see that depending of the style of the mastodynia, we can have good result or not. And you see here what is very important: the bra, the psychological activity, the reassurance, the methylxanthine avoidance, and of course the Agnus castus with the GLA. That are very important. After this, we have stronger drugs like bromocriptine, danazole, and sometimes tamoxifen for a few days per month, and progesterone and progestative that we can give, of course, to help the balance estrogen-progesterone. At the end of this, we can see here one flow chart of management of breast pain. After the physical examination, we perform ultrasound and sometimes mammography, and there is no finding reassurance. If we have something, we divide on two categories: cyclical mastalgia or non-cyclical mastalgia. If it is cyclical mastalgia, we use anti-inflammatories, progestogen, pills, evening primrose, Vitex, or bromocriptine. And if it's not enough, we can go to stronger drugs like tamoxifen, danatrol, or LH analogs. In the case of non-cyclical mastalgia, we can use local or general anti-inflammatories to decrease the local inflammation and to treat the patient. Actually, it's necessary to use everything but to reassure the patient and to prevent breast cancer, making, of course, always mammography and ultrasound. That's our view. Thank you.
Any question? I ask you, I tried to use the progesterone gel, but I don't know why it is available in some countries. Other countries, they never hear about it.
Well, so this was first developed in France by the team of Mauvais Jarvis in Paris, and the name is progestogel. This exists in Romania, that is mastoprofen in German. In Greece, it is mastopon. There is many countries. In Brazil, it's also progestin. It is very useful because the possibility to have local absorption decrease the level of the estrogen in the breast, and we have a good balance.
It was very effective. But
you can buy it from Greece or from Romania or from France, Germany. You have it.
Is it here available in Turkey?
In Turkey, I don't know. Yeah, they have.
No, we do not use those kind of agents for the cyclic or the non-cyclic mastalgia.
Okay. Come in the Greek islands. You can buy it there.
The reasons, as you mentioned,
yeah.
Is the bra size in general, because women use the same bra size beginning from the middle school until the university, so you have to emphasize that. The second one is the consumption of the coffee and those kind of things. And then if you just confirm that the lady do not have any kind of malignancy, then it is psychosocial. So they are relieved, and you usually do not need any kind of the other kind of systemic treatment.
But you can use together Agnus castus,
yes,
Vitex,
EPR,
with evening primrose.
Yeah,
This is very good.
EPR is very nice, and as you know, Agnus castus and the EPR all have only level 2 evidence, not the level 1. But
in practice, it's good. You can trust me.
Absolutely good. We use both of them. But the other conventional therapies affect more than ever.
Yeah.
Thank you very much.
You're welcome.
For the next presentation, I would like to invite you, Professor Vlatica from Constanța, Romania. Domnul profesor, aș dori să vi-l prezent pe din Constanța, Romania.
Your Romanian is perfect. Hello. So, most of you, the most courageous, are still here. So, by the way I'm going up, I thank you, the organizers. I thank my friend, my beloved friend, Professor Gologlu, for inviting me here. So, and I'm very happy from the sense of the Mastology Association of Mediterranean Association of Mastology that we are all around the countries, but also around the specialties. I'm invited today. I have an easier task because of two reasons. First, because the subject is shorter. Tomorrow it will be impossible. I don't know if we will survive after my presentation of tomorrow morning, very early in the morning. Second is because many of the things are provided here were already said. For instance, Professor Zervoudis just told you about pain. I will speak about pain. I will not inflict pain, but I will talk about pain. But most of it was already discussed and presented, even during the discussion. So I'm very happy. The most of the things we are here is because we have this thing, which is a change. So it is a change, and I'm stressing it is a change, not a disease. And that's involving us, gynecologists, I'm a gynecologist, surgeons, endocrinologists, family practitioners, recuperation medicine, whoever is not involved in a woman coming and saying, "Doctor, I have pain." Well, this is very interesting because if not, it is important. It is important because, as you see, it is very frequent. It is the very first, the very most common consultation reason, and it is, of course, during the fertility years. Now, the most of the things is to reassure, and Professor Zervoudis, I'm citing him again, said this during the treatment. Then, if we go a little bit more towards this not disease, if we have to try, but reason to try to have a definition, well, it is very difficult. First, because it is enhanced reaction of the breast tissue. So it's a normal tissue, sort of a normal, we will see, but with an enhanced reaction. And this is going through the fibrosis, dense fibrosis, towards proliferation, and then metaplasia. This we will talk about afterwards a little bit, and then to cysts. And this is important because the cysts are very frequent. As you can see, more than 1 out of 3 women will have cysts in the breast. So what? This is not a disease. Again, we will not treat the disease. We will treat, but not do surgery unless some specific cases. Especially because some of you are surgeons, some of us do surgery, and we are something tempted. Do not do it. Then, if we go to the lady who comes to us and do the history, of course, we will ask about risk factors. And most of the risk factors here deal with hormones. Then again, Professor already told us about hormones because of no pregnancy, no lactation, no prolactin and estrogens, early menarche, so a lot of estrogens, no progesterones. There is some genetic, there are a high importance of socio-economical, intellectual, professional environment. We have a little bit of diabetes, and it is in the upper outer breast part is a more breast tissue. Now, the pathophysiology, we can do it in 2 or 3 or 4 steps. So we have stromal fibrosis. Do you remember? I said stromal fibrosis. What did I say, if not stromal fibrosis? The other one was what? So fibrosis. The next one, what did you say to me? Help me. Cyst formation. That will be here. Cyst formation is here. Yeah, Professor Tamer sees what you don't see, but he sees it. So what? So fibrosis, cyst, epithelium. So we do stromal because that will be obstructing ducts. Will be some epithelium and retained something, and we'll have cysts. And cysts, as you can see here, is almost half of them can have cysts. Now, the etiology, we talked about hormones, we talked about genetics. There is some vascular pathology, there is a lot of psychology, well, it's a psycho or a disease or condition, okay? And these methylxanthines and this is because those, and again we can come to tea, coffee, and those like that. The idea, because we can ask me, okay, what is with this? They tend to decrease the transformation of cyclic IMP, and then we will have no enough more than 3T, so we'll have this cycle CMP is giving some pain, not towards gamma transmission, but per se. Okay, so pain. I'll go quickly. Pain was already discussed, so it gives me some time. Now, what can we do if we examine this lady? First, of course, we have the either tenderness or nodularity or even a dominant mass. Then, if we have a dominant mass, we are tempted to do more than just observe or give some hormones. And this is sometimes guiding us. Of course, we can see the skin. The skin should not have any problems, because if the skin has problems, it's not this condition. It might be something else. Okay. The adenopathy, we should not have, okay, we can have a ganglia. That's normal. I remember when I was in the 4th year, I went to my professor asking him if I don't have cancer with metastasis, because I have some ganglia here. And he smiled, he palpated me, he said, okay, you're healthy. Of course, they have ganglia. They can have inflammatory ganglia, but not big ganglia. So if they have less than 1 centimeter, if they are mobile, these are not suspicious ganglia. They are not suspicious adenopathy. And the nipple discharge. The nipple discharge can be greenish, okay? But of course, we will have the red nipple discharge, which is a sign we should not avoid making some more examination, some more monitoring. Okay, we can also go and see the general embryological and hormonal impact on the lady, axillary, pubic, just breast, other sexual transformations. Now, the first line, after taking history and examining the lady, the first line, and in the most cases, the only resting line is ultrasound. Because ultrasound, and then again, we had this comparison between ultrasound and other more expensive ways, is enough. It can do, you can see here a lot of shadows and even echoes. We can have this examination, all the breast, in the axillary, subclavicular, and laterocervical. Then here is not for mastodynia, for fibrocystic disease. Here is retrosternal-hepatic if we suspect something else, of course. It is not for fibrocystic disease. Now, this ultrasound, the most important figure here is not the accuracy. You see, the accuracy is not great. It's 70%. 70% is not great. More important is the sensitivity. So let's say that in 9 cases out of 10, 9 patients out of 10, we will define the thing. We'll see, okay, this is a fibrocystic condition. But the most important is this one. In almost all the cases, we will say, lady, this is not a cancer. I will not do surgery. These are very important. So the negative prevalence value, this is more important because it's almost, it goes up to, you see, more towards the impossible 100%. All right, we can have mammography, and you see here a mammograph doing this. It's these opacities, irregular dense zones. This is no disorganization. Sometimes we can see sometimes microcalcification, but these microcalcifications are not suspicious. And you know, because in mammography we have the BI-RADS classification, so we can, if we are here or mostly here, we are satisfied. Now we can go even further. We can have MRI, of course. We can have MRI, but also I would say again, only if we have some suspicious, some differential diagnosis to be put, as well as other kinds of examination, like thermography, histography, and some biomarkers. Now, biopsy. The biopsy we will do only if we don't know what it is, only sometimes if it is a dominant mass, as I already said, or if the ultrasound gives us a suspicious imaging, so we don't do biopsy. For every patient, or for the most of the patients, who come with a cystic disease. We have the FNA, we have the core, which is better, of course, and we have the surgery. Okay, you see, when imaging cytology is insufficient, please keep in mind this. We don't do this unless it is really necessary. Let me do, if I can, something. Okay, so finally, we have an instrument. We have an instrument which is called the triple test. The triple test is the first two ones are more important. So the physical imagining. The imaging is completing very, very well the session done by history, by examination. And sometimes we need cytology. Sometimes we need cytology, especially when as I told you, in specific cases. And this can be done either by FNA or by core biopsy. This triple test is very good because you remember we have 74% of sensitivity. So that was not very good. Well, with the triple test, look, we have accuracy of 95%. 95% is very much. In medicine, it's towards 100%. Now, what else? Well, mastalgia. Again, I will go over the pain because pain is not only given by breast, and as you said, we will go over by breast differential like nipple discharge, galactorrhea, or blood, by mass, which is especially if we are more than 50, but more than 50 is not this condition. You remember it is mostly between 20 and 50, because after 50 the risk of cancer, the suspicion of cancer is increasing, and solid tumors and microcalcifications. The risk of cancer. One of the major things to talk about, the risk of cancer when we have those no adenosis, fibrosis, mild hyperplasia is not. Then we have hyperplasia, then we don't go, we are stopped in the fibrocystic disease. We go in something else, and then, of course, the risk of cancer goes 1 to 14 times more, especially we have complex cysts. All right. Treatment. Non-hormonal treatment, I agree again with what was said. We see symptoms, rule out cancer, reassure, and follow up. All those things are very important. We have lifestyle, bra, okay, already presented, diet, already presented, vasotonics, because I told you that one of the, in pathology, one of the risk factors are vaso pathology, so this is vasotonics are important. Psychological, minerals, and some diuretics because there is a sort of edema in there. We can give hormones. Again, that was presented. I rather prefer the gel, the progestogel or matoprofen, but we can give also, if we don't have the topical gel, we can give dydrogesterone, chlormandione, and some others. Now, bromocriptine, you see, bromocriptine is very efficient. It's decreasing by 60 to 80% the symptoms, but we have some side effects, like nausea, like headache. So certainly it's not the first line of treatment. We can give danazol, but again, danazol is not, it's effective, but it is not even the second line of treatment because it gives some other side effects which are not wanted by us. And we have the agonists, but the agonists or the antagonists also, if we don't, the agonists have the flare-up and then no stimulation, and the antagonists directly, but all of them puts this patient in sort of a iatrogenic menopause. Now, the surgery, and that would be the last thing to say not to do again, unless we have a suspicion of something else, that fibrocystic disease, and then it would be indicated. We can, I said, we can use FNA. We can have true cut, and of course we can have surgical excision. And you see, there are some indications here, and that thing it's important because either we have concerning cysts. You remember if we have complex cysts, how much we can increase the risk of cancer? You remember? 14. You see, 14 times. So then we should do something. We should do, for instance, FNA or core biopsy. That's very important. Or if we have no fluid, if we have a recurrent mass after treatment, if we have bloody fluid, and I said bloody fluid, this is not good. Okay? And if we have, well, all those things, then we can do surgical biopsy. So, I look on my time, and I have another 3 minutes. But I finished my presentation. I tried to. Was I running? Yes, it was a long presentation. So, conclusions. What would be, from your point of view, the first conclusion? I can wait. I have another 3 minutes. What do you think? What would be the conclusions? I want to put some conclusions here. What conclusions? What would be the take-home messages from this presentation? It is not a disease. Wonderful. This is not a disease. This is a condition. But it is a condition which can be invalidating. So it is a condition which can trigger pain, sufferance. So even if it is not a disease, we should monitor and assess it very carefully and do something with it. Second or third conclusion. No need for surgery. All right. If we don't have any suspicion. All right. So how do we treat it? Because we have pain. Reassurance, psychological. Okay. So reassurance. What else can we do? Lifestyle. What else? If this doesn't work, progesterone. All right. Okay. You don't treat. Good for you. Good for you. Don't treat it. But if the lady comes, I agree with you. Don't treat. I don't treat fibrocystic disease. I treat the pain of the fibrocystic disease. So I don't treat because it's a condition. Okay. It's like ladies coming to me and I said, I don't operate fibromas. Oh, okay, you don't operate. No, I operate women with fibromas causing some problems with women. So no, we don't treat fibrocystic disease, but we treat the symptoms. We treat if the lady has problems. The fibrocystic disease is a condition, but the pain, then we should treat, unless we don't have a suspicion. Okay, and the treatment can be lifestyle, can be progesterone. The reassurance, thank you very much. It was correct. Now I finish. Okay. So, thank you very much for this. I thank you. It's çok teşekkür ediyorum. Okay. Thank you very much.
Better than my Romanian language.
You did my presentation.
Better than my Romanian language.
I'm not sure. I'm not sure about that.
Any questions from the audience? I would like to emphasize and comment one thing.
If we can substitute bromocriptine if you have problems, nausea, etc., with cabergoline.
Yeah, I don't have, I think that from the scientific point of view, you are correct. I don't have experience in that. But I try, I have to recognize, I have to confess that I never use bromocriptine because I succeeded in doing something just before. I said bromocriptine, danazole, GnRH, agonists are really, I have to tell you because we have we have to have didactic presentations, but these are really the last ones we introduced because of the side effects.
Any points from the audience? I have a point.
Please.
Thank you very much for your kind. Yes, after that I will give the floor.
There is a hand there.
I have to make a comment and I will give the word to you, okay? So regarding the take-home message, I think we must just exclude the surgical excision point for any kind of fibrocystic changes.
Yeah.
If you have any kind of question and suspicion regarding the malignancy, you have to perform core biopsy, not an FNA. If you have a complex cyst with the solid component, you have to perform a core biopsy from the solid component.
Yeah, better.
And then, if you do not have any kind of diagnosis, so the surgical excision is nothing to be emphasized regarding the fibrocystic changes. Thank you very much. And
very correct, very correct.
From Kocaeli Üniversitesi, Istanbul. We are always talking about lifestyle change in the first step, about breast pain, fibrocystic change. How much does a surgeon has to spend with the patient about changing lifestyle?
Yeah, very good point. Well, then I have to confess a second thing. I'm also a psychotherapist, and my attitude towards women is a little bit different. So I like talking to women, and I like listening to women. So my secretary tells me, hey, the clock is ticking. And sometimes I almost always go over my schedule because I take some time. It is not very much because I'm asking, okay, when is this hurting, cyclic or not? Okay, are you very intellectual? Do you work a lot? Do you sleep a lot? And then do you drink a lot of coffee, a lot of tea? And then it takes me not more than 2 or 3 minutes. Okay, this is 2 or 3 minutes. Please.
Maybe you know also in Romania there is a community about lifestyle medicine.
Mm-hmm. Yes, it is.
Do you send your patients to these kind of doctors if the patient is interested about changing lifestyle?
So, first of all, I heard about this association or society just 1 month ago. But I know that it exists. Second, we developed a very different way of teaching, which is non-surgical skills of a surgeon, which is, I could talk about that masterclass. I developed a European masterclass on that. So, I did not, because I don't remember women patients whom I did not succeed having the result, or they abandoned me because they didn't have and went to other doctors. So my patients, the patient I saw, didn't necessitate something else than what we did. Finally, the pain diminished and the reassurance worked very well.
Okay.
Thank you.
Thank you, Professor, for your nice presentation. And please.
Here you go.
Professor Vaucelescu from Romania will speak to us about rare skin and nipple changes.
Thank you for inviting me here, and I'm very honored. And also, it's a very difficult task to talk to you about something rare after such important themes you have before. It's also a challenge to, after not being bored by speaking about such a frequent theme, and this is the merit of my this is the challenge. I shall try to bore you about rare things. So we shall have, this is one. Okay, I shall try to make a small organization here and to speak you that the changes, even rare or frequent, of the skin and the nipple may be constitutional, and this you saw that may be number of or localization of these, and it was already told. About the changes of the protrusion of areola and nipple, and also this it was presented. The acquired changes may be discoloration, and here we have a large spectrum from hypo to hyper and or abnormal pigmentation. The infections, and it was already spoken, so this is my task. And also we have degenerative changes in the skin and nipple, and also tumors that may be retentional, the cysts in that region, or ectasia, and also proliferative tumors, epithelial, glandular, vascular. So about the nipple anomalies, I shall let the pictures to speak for me, and sure you may see that sometimes. So you can see sometimes the lady with abnormality is even proud of her originality. Sometimes we have breast in breast, but it's not a hamartoma, it's another gland here, multiple nipples, or ectopic breast tissue on the shoulder, or even here. It's just to be noted. You saw it was nicer, the picture you saw before with the other glandular tissue and nipples. Yes, very nice picture. Also, it's a sort of abnormality. It's rarely seen. Usually we have the secondary nipples below, but we can have them also. Here we have a glandular tissue with a small nipple on the type, big areola and nipples, polymastia, tuberous breasts, synmastia. I thought it's only produced, but I saw also this. Sometimes gynecomastia, gigantomastia, some dyskinesia of the nipples, and so on. And also sometimes the traumatic lesions may be peculiar, such as the joker's nipple. It's after jogging, but with bad equipment. Or burns, solar or boiling liquids, or after radiation. And sometimes they are leaving scars, and these are after RFA trying to make tightening the breast, so it was a great success. Some after burn scarring tissue, or after traumatic, you see then this is the safety belt, not very nice. And also we shall speak about dermatitis, but not about this. These are frequent, but sometimes you can see secondary syphilis lesions or hidradenitis of the breast, or some psychosis that is quite streptococcal infection, some kind of fasciitis and or nipple infections after piercing. We can have also breast dermatitis, non-bacterial, and this may be immune. Stephen-Johnson or Lyell syndrome, pemphigus. You may see here herpes or other viral eruptions. Candidosis of breast and of nipple and areola, and some parasites, plants fly with a larva getting out from the breast, or filaria, or here is a bed bug, or after filaria you can filaria you may have also a breast lymphedema. Or also dermatosis, not exactly allergodermia, but sometimes it may be quite peculiar, or kind of eczemas of the areola and nipple, or hyperkeratosis, even horns on the nipple, also a kind of psoriatic eruption on the breast, and these have many forms, but most peculiar may be the inverse psoriasis. Usually it is sparing the folds, but in the inverse it's of the flexure site, or the Barrett form of psoriasis in lactation, with lesions like this. And how shall we do to manage this? We are surgeons, so it's the diversion, not surgical treatment, but we shall try to prevent by gentle hygiene, and this, you know what it means, or using loose breathable clothes. And if it occurs, we can think about some local antiseptics are very useful, also in preventing relapses, or using some local antibiotics, or some D or A vitamin derivatives, or mild cortisons applied or injected, or inhibitors of calcineurin for all these dermatosis, and another great list of drugs, and also phototherapy may be used. Also, we may think to discoloration of the breast, and we have vitiligo lesions on the nipple and areola. We have also some hyperpigmentations that may be a lot of things. Please also think that if it's hyperpigmented, the areola and nipple, that this may be the onset of an Addison disease. And also there are some pigmented moles and melanoacanthomas like this. Sometimes it's a vascular phenomenon. The Raynaud's syndrome may affect also the nipple, and with its biphasic evolution, first of all, it's the spasm with the pallor, you can see also on the fingers, and after that is vasodilatation with congestion, with pain, sure, and also some other kind of discolorations, café au lait or pityriasis, versicolor lesion. And if we have something like this, we may think of specific treatment, or if we try to do tattoos or even remove that ugly lesion. For the exophytic proliferation, sure, we have moles that may be achromic or melanotic. We may have words, and these may be like this, but they may be also like this. We have neurofibromatosis. We have a lot of kind of papillomas on the breast, condylomas also, and also we have here another lesion is the nipple in the nipple, or fibrotic papilloma. Vascular changes, sure that we can see telangiectasia on the breast, but sometimes they are evolving ugly. Sometimes we have kind of angiomatosis. This is a rare condition of the breast, or hemangioma of the breast. Here is also hemangioma. Here is also hemangioma, or lymphangioma, and sometimes there are with melanotic changes like this. We have also phlebitis or truncular lymphangitis of the breast, Mondor or Moscovitch disease, as you see here, and here is the truncular lymphangitis. And this may cause us to have rare mammographic peaks, and here you have in a tubular breast, you can see the glandular tissue within the areola. You may see the second breast here on the mammogram, or better here. You may see a retentional cyst. You may see a filaria with calcification sometimes. But I am performing ultrasound, and I want to sell you ultrasound. So I shall make you see how it can help us. For example, this is a herpetic lesion. It's very small, tiny lesion, but we can see very well in ultrasound here. The Zuska disease, you can see the limitation of the abscess. It's a very good view. Also, nipple syringoma, and you can see here the tumor with hyper Doppler signaling, or the second nipple, or also you can see the filaria, and here you can imagine that this is dancing. This is very nice if it's dancing, but I have only the picture. So you must trust me, it is dancing. Also, we may speak of some conditions, are conditions of the nipple areola complex, and this is starting with Montgomery glands that may be evolved to cysts. You can see here that this is secreting, and this may be inflamed and make a retentional abscess. And you may see here the ultrasound correspondence, another case in a man, and you may do anything what you want, also mammogram to see this, and elastography. The point is that in such cases you may have pain and the whitish discharge and the bump, and you may use this imagistic methods and making a simple incision to evacuate and giving antibiotics, it will be enough. After that, we have some adenomas, and now I will speak about three kinds of lesions, but they are so nicely related that it's like adenoma and fibroadenoma and phyllodes tumor you heard in the morning. This is the same thing, and this is quite a rare disease usually, but it's exceptional in the nipple because usually it's in the breast. So I had this image, but I didn't have the following up of this. I get another image on an accessory gland that was transformed by a tubular adenoma. This is firm and mobile, very well defined mass. It's painless and rarely it has some features that are irregular borders or fixation or ulceration. This is rare. And what we shall think about, it has two layers, luminal epithelial and myoepithelial cells. We shall see rarely mitosis in these cases, and sometimes we have some secretion endoluminal. We propose the complete excision or observation because it's a lesion of low risk of malignancy. The other kind of adenoma is syringomatous tumor, and this is also very rare, but this is on the nipple and areola. I found only 34 cases. This is about 40 years of age. There are also two men in this trial, this cohort, and also two cases of bilateral lesion. This is originating probably in the eccrine sweat gland of the nipple. It's a small mass, but circumscribed, and it may be relatively fixed, and it may produce nipple retraction, as you see here, and give sometimes skin changes. This may be producing a crust or an ulcer on the skin. Usually it's not painful, but it may be also painful, and it may have nipple discharge. As you see, we have some images that showing us the circumscribed condition. You already saw this image of ultrasound for this kind of tumor. And what shall we do? We shall do, however, a biopsy because it looks not so nice. And if we are doing our biopsy, we shall see some tubules in a teardrop coma or branching shape like this. This is very specific. Two layer of epithelium. This is also important because we may speak about differences with the other kind of adenoma, and also the stroma may be hyaline or myxoid, and the tumor is infiltrating, and sometimes even with perineural infiltration. It has some squamous metaplasia and negative stains of hormone receptors. This we have also to make complete excision. Also it has low risk of cancer. But it looks very bad, and it's ulcerating, it's infiltrating. A rare condition, but this is only on the nipple, so this belongs to the nipple. It's the nipple adenoma, and you may see that it's about middle-aged women, but we have also some 5% men, and this may be an unencapsulated relatively small tumor. It may grow up to 3.5 centimeters. It's erosive, it's ulcerating, it's deforming the nipple. It may have a discharge or even bleeding, and also may have a crust here. Bad news, it's very difficult clinically to distinguish. Practically it's undistinguishable from Paget's disease, but we have, happily, we have imagery. But no, because also mammograph and whatever, it's unspecific. So maybe the pathologist will help us, but no, with the cytology, we have Toker cells in the epithelium, so this may look like Paget cells. So we must do a punch biopsy or a core needle biopsy, and only then we can have our diagnosis, and we have some major morphological patterns there. We think that this may have necrosis. This is a very important factor, because usually when we are seeing necrosis, we are thinking malignancy, but no, this is benign. Also, we have hemorrhage, we have inflammation, we have a lot of things to tell us it's a danger there. And in fact, if we are seeing it's hyperplasia papillary or sclerosing adenosis or mixed pattern, but seeing hyperplasia, we have HER2 negative. This is also important, because for that reason we can have this ulceration and a lot of bad things. But P63 is positive. This is a marker of myoepithelial cells, so we are relieved. And about the hormone receptor, this may be variable. It often associates squamous or apocrine metaplasia, acanthosis, even cysts. And in the epidermis, we have Toker cell hyperplasia. This is important, that this hyperplasia, so we have sometimes a lot of these cells. And this must be differentiated from Paget cells. So what shall we do with such a lesion? We want to make the complete excision, because this time we face lesion with higher risk of malignancy. Even it's rare, but on the series we observe some a little bit more than 10% risk of malignancy. This means even associating malignancy, even transforming in time in a malignancy. And I hope that I didn't bore you so much. I thank you for the attention. Teşekkür ederim. And I am inviting you, everybody is doing an invitation today. I was very honored to be here, and so I'm inviting you to our conference next year in April, and thank you.
Okay, we thank you. Any last words from the audience? Questions? Okay, thank you very much. It was really a great honor and privilege for me to be here to moderate this session with Professor Yusuf and Professor Güler, so it's time to close the last session. Have a good evening and see you tomorrow. Thank you very much. We would like to have a photo together with the lecturers, please.